Sir, thank you very much.
Arranged by Pakistan Medical University annually to give us opportunity to benefit from the valuable experience of highly learned clinicians and doctors coming from different parts of the world. In this session, our speakers would share their knowledge and experience about cervical and breast cancer screening, and both are very common cancers in Pakistan. Pakistan has the highest incidence rate of breast cancer among Asian countries, with 1 out of 9 women being at risk of developing breast cancer. And cervical cancer, which is a preventable and a very curable cancer, it's still the third most common cancer in Pakistan. And as we know that cancer prognosis is largely dependent on the stage of the disease, and thus screening and early detection enables better prognosis. So that is why this session is arranged. To begin today's proceedings formally, I would like to call upon Dr. Rita Zainab for a recitation of Holy Quran. So now to begin the session, I would like to call our worthy and honorable guests, our speakers. And first of all, I would like to introduce, as Chemical Chair, we have with us Professor Dr. Muhammad Shafiq Gill. He's consultant histopathologist and head of service histopathology at Sherwood Forest Hospital NHS Foundation Trust UK. His special area of interest is breast and lung cancer. He's Associate Medical Director of Clinical Diversity Inclusion and Medical Leadership at Nottingham University Hospital NHS Trust. And he has a vast experience of developing assurance systems working in collaboration with national regulatory bodies like Care Quality Commission and United Kingdom Accreditation Services in England. Sir, please come to the stage and take the chair. As FJ UHC Breast, who's graduate of Fatma Jinnah Medical University. She's chairperson, Department of Pathology at Fatma Jinnah Medical University. She's Dean Basic Sciences at Allied. She is certified medical educationist and has served her alma mater over 30 years in various capacities. Madam, please take this. We have with us Professor Zora Khanum. She's head of gynae emergencies at the Garam Hospital, Fatma Jinnah Medical University. She's Dean Nursing and Allied, Fatma Jinnah Medical University. She's a qualified endoscopic surgeon and a great clinician. She's a medical educationist and has many national and international research papers. So with us, our student chair, Dr. Kamal Masheen, who's working as consultant gynecologist in Gynae Unit 1, Sargagaram Hospital, Fatma Jinnah Medical University. She's a very active learner and a very active worker and a very competent clinician. Please. So we have our first speaker online. He's going to join us from UK online. I would like to introduce Professor Dr. Shahzad Ali Khan. He is graduate of King Edward Medical College. He is PhD in Medical Sciences in Pakistan and he holds Fellowship of Royal College of Physicians and Surgeons, London, UK. And he holds Fellowship of Royal Society of Public Health, London, UK. Currently, he is the Vice Chancellor of Health Services Academy, Islamabad, and he holds 199 publications to his credit, and he carries vast teaching and research experience. The topic he will talk about is tackling cancer burden in Pakistan, a public health perspective. We welcome you, sir.
Thank you very much. Am I audible?
Yes, sir. We can hear you very well.
अच्छा जरा आईटी को अपनी कहें कि ये मुझे शेयर स्क्रीन की ऑप्शन दे दे जरा।
Sure.
My presentation अगर आप अपना लगाना चाहती हैं तो बताइए बट I can share.
Oh, okay, sir. We're sharing the screen.
Actually, it is able me to have us. हमारा स्पीक एक्सपर्ट का लखनऊ का इवेंट भी है लाहौर में, तो बट मुझे लगता है कि ये शायद अभी टाइम नहीं मिलेगा. सो थैंक यू वेरी मच. नेक्स्ट करें जरा. If you see the risk factors of public health or health and the death caused by various risk factors, you can find that out of 10 top 10 killers, top 10 death risk factors, almost 7 of them are related to non-communicable diseases. And we thought 20 years ago, we thought that the developing countries have these chronic diseases in the form of cancers, diabetes, and heart diseases. They have this problem. In the developing countries, they have a problem of communicable disease. And there's a huge spike of non-communicable diseases, including cancers. So this is the deaths in millions. So the deaths in millions are increasing in the developing regions. Next, correct? इसी को देखते हुए WHO ने और दुनिया के बाकी इदारों ने बहुत ज़्यादा इस पर काम करना शुरू किया. हमने भी बड़ा पिछले 20 सालों में मैं सानिया लिस्टर का PhD का, तो डॉक्टर सानिया लिस्टर is famous for her work in non-communicable disease, especially heart disease. She has a PhD in preventive cardiology from King's College London. तो हम सब काम कर रहे थे, तो हम जब जाते थे किसी भी डिसीजन मेकर के पास, पॉलिटिशियंस के पास, तो वो हमारा मजाक उड़ाता था. वो कहता था यार आप क्या बातें करते हैं यहाँ. तो the burden of non-communicable disease in Pakistan, cancer is second to heart disease and cardiovascular diseases. If you see, there are around 679,800 estimated deaths, और उसमें से फीमेल थोड़ी सी deaths फीमेल की कैंसर से कम है, लेकिन NCD से कम है. लेकिन ये आप देखें कि 33 other countries. Next. So next, so globally, whenever we call anything related to cancer mortality or non-communicable disease, the big three always come up with like the eating, like the diet, Well, what we eat, what we drink, and how do we move. Next, correct? So the poor diet, physical inactivity, and stress is one of the biggest reason for cancer mortality globally. Next, comment. ये पूरा एक दफा सारी स्लाइड शो करा दें करते जाएं. So if we see in Pakistan, most common burden of cancer and the heart disease and diabetes is related to food and diet. So if you see, we have a very high intake. We are one of the highest intake of oil in the world. Very high intake of sugar and salt. Our diet is always rich in TFAs, trans fatty acids. We don't take vegetable and fruit on a daily basis. मैं बाजार में भी तो कहता हूँ कि हम शादियों पे जाते हैं तो वहाँ पे सिर्फ सलाद खाते हैं. घर में हमारा सैलेड खाने का कंसेप्ट ही खत्म हो गया. फ्रेश सैलेड 2 सर्विंग चाहिए होती है, 1 सर्विंग ऑफ फ्रूट चाहिए होता है. We don't do that. Obesity is very high. It is on the rise in male and female. It is highest in the age group of 45 to 64. Now this is the vulnerable group for all cancers as well. If you see the age group, the last line, it is 40% in the urban areas in females of 45 to 64 years. And this is all various surveys which are telling us these things. Among these 45 to 65-year-old females, 65% are not only obese, they are also hypertension. And among these 45 to 64-year females, 25% suffer from diabetes. So it's a triple burden of disease among these group of women. So this is a very high intervention area. The female from 40 to 65 years, we need a lot of public health intervention so that they can maintain their weight and their, the hormonal and other things also start coming up by the age of 45 to 50. So this is something we need to focus on. Next, correct? Next. So कैंसर में अगर आप देखें, हमारे पास पहली बात तो ये है कि we lack national level data. There are some registries, localized registries who are getting this database. There is a very big database in the institute where they are having a diabetes registry and other registry, but cancer registry, it was started by asking to in Karachi, but I don't think that even upscale to the national level. So there is a problem of data, but then if you see the incidence, it is very high. Incidence rate of all cancer is 7 per 100,000. So in male, also lung cancer is the most frequent one. In female, very high proportion of number of new cases. So the number of new cases in 2020, and this is the Global Cancer Registry, Global Cancer Observatory, GCO. And it is available at the WHO website. You can all Google and write Global Cancer Observatory, and you can get at how Pakistan real time they update almost every month. So if you see the breast cancer being the highest, around 15% protein cancer, 25,928 cases in around 2020. Then there is lip and oral cavity, lung, esophagus, colorectal, and then there are other cancers. But if you find the cancer between the second and third, you see there are males and females. So in females, the breast cancer is the highest one, and in males, you can see that the lip and oral cavity cancer in Pakistan has bypassed the lung cancer. So whether it's diagnostic or something else, the number of new cases of lip and oral cavity cancer, oral cancers, they have increased and they are higher than the lung cancer now. So it is number one according to this observatory. And this, remember, this is all through the registry and then the diagnosis. So the real problem we don't know. This is just because the incidence is dependent on diagnosis. So this is being diagnosed more commonly. And if you see female, the breast cancer and then the lip and oral cavity cancer again over there, cervix, cervical cancer, and then esophagus cancer. So this is very, very alarming that we are having such high numbers. If you see the age-wise incidence, you can identify on the right side that the breast cancer is the biggest killer in the world. Then there is the lip and oral cavity, and then lung cancer, and then esophagus and colorectal cancer. Number of new cases you can see 178, 388, number of deaths 117, 149, and prevalent cases is 329, 507. This is something which is not only there is an age-related factor Pakistan, the cancers come at an early age as compared to developed countries. Next, correct? Next. Thank you. So the number one area where public health can intervene is that we have to have an integrated non-communicable diseases policy. We cannot have action plans, solo action plans for heart diseases separately, for cancer separately, and for diabetes. So if there are common risk factors, like I mentioned, the diet, the physical inactivity, obesity, as well as various form of stresses. The stress. This is something which is very important for all of us, that we should develop an integrated policy. This is not the job of the health sector only. That we need a multi-sectoral strategy. There is a very limited budget for NCD prevention. Tobacco is still relatively high. Tobacco industry is making advertisement, and the smoking rate is getting higher and higher in the form of cigarettes, shisha, and other different types of tobacco use. And we do not do something like this increased budgetary allocation, so we cannot do much if we want to do that. Next step. So the first area was governance, the second area was prevention and reduction of risk factors. So of course, tobacco and healthy lifestyle promotion, this is something which we have to do. Food and promoting physical activity, and that is something which we are focusing nowadays, and more and more advocacy is being done for increasing this physical activity and improving healthy diet, and definitely doing something about this stress. Next thing. There is a very high demand for surveillance, monitoring, and evaluation. We do not evaluate. So this is something we need to have this not only the data, the surveillance, the monitoring, evaluation, and governance component. We also need to improve this lot of intervention in the healthcare delivery system. So in our tertiary care facilities, in our secondary care facilities, we need to improve the system at a basic health unit or an RSC or as a GP. The processing of that case to the real the proper place where the cancer or the CVD or diabetes will be managed it takes more time. So we did some research and we found out that there is a huge system delay and proper care starts very late. And in cancer, every day is very critical, very important. Next one.
Sir, last 3 minutes.
This is also, so whatever we have done is we have integrated some of the provincial strategies into national NCD policy. We have started provincial consultations of NCD units have been established. The NCD non-communicable disease focal person has been notified. Next, correct. Tobacco tobacco control. एक दफा और दबा दें, एंटर करें. Yeah. So tobacco control FCDC has been implemented, and there is a focus on more implementation, communication strategy, harm reduction strategy. Next. So we have developed some of the NCDs into the district health system. The global youth tobacco survey was done in Pakistan. National dashboard of various non-communicable diseases are established, and they are getting some data. We are working on cancer registries, which is a very difficult task because there are a lot of private providers who are dealing with cancer as well. So getting data from a private hospital or a private GP is very difficult. That is a big problem. Next, correct. So we have essential health service package included in NCDs, and essential drug list is included in NCDs. Next, correct. This is the last slide. What is needed? So we need to build on the previous efforts. Don't start reinventing the wheel. Whatever has been done in non-communicable disease control, build on that. Not only build on that, build the capacity of the health workforce in cancer detection, in management of other various diseases, and definitely develop partnership with the private sector and other for integrated NCD control. So I stop here. Thank you very much, and I will be available for if there are any questions.
Welcome to all at FJ University and especially to our body guests. This is my presentation is very brief presentation, just in continuity what we are talking about the cancer, and it is just in continuity I will talk about the cancer registry in Pakistan, and especially I will just focus on the importance of cancer registry in Pakistan. Today honestly if we just talk about कि अगर आज इस hospital I am very honest at the moment कि अगर आज इस hospital का data भी हो हमारे पास कि gynecological cancer कितना patient हम देख रहे हैं तो सर हमारे पास कोई accurate data नहीं होगा. There are multiple factors. It's not like that we don't want to keep it. It is just like the metro system and organizations of the system. Because when we just deal in our OPD at the moment, we deal about 700 to 1,000 gynecological and obstetrical patients outpatient department. And it's about more than 300 emergencies, obstetrical and gynecological emergencies in 24 hours. And our workload for obstetrics is about 100 maternities in 24 hours. We just imagine the workload and the referent being a female जो है ना वो साधारण हम कहते हैं वो जनाना अस्पताल में गए ना अभी तकरीबन के लाहौर में we just take the emergencies from all over the Punjab and especially from the अंदरूनी शहर कि वो जो केस करवाना है ना वो हमने जनाना उसमें के माहौल में करवाना है. So that but because of the heavy workload and because of just maybe कि अभी हम evolution process में चल रहे हैं बेहतर से बेहतरी की तरफ जा रहे हैं तो हमारे पास इस वक्त क्लेम्सिया का बिल्कुल डाटा रजिस्ट्री होएगी, एंटीपार्टम हेमरेज की होएगी, लेकिन कैंसर्स की नहीं है. Although we have the very efficient working tumor board here in the university, वो पैथोलॉजी डिपार्टमेंट के पूरा ग्रेटफुल प्रोफेसर फरूक बैठे हुए हैं, इन्होंने स्टार्ट किया प्रोफेसर नज़ा उसको कंटिन्यू कर रही हैं. हमारा अपना ट्यूमर बोर्ड है यहाँ पर, लेकिन ट्यूमर बोर्ड में वही केस जाते हैं जो डिस्कशन के लिए जाते हैं. इट्स नॉट लाइक कि आज का जो गायनी का ओपीडी हुआ था उसमें हमारे पास कितने जो हमारे पास गायनी के ओपीडी में इतने 100 पेशेंट्स आए हैं उनमें से कितने थे जो प्री मैलिग्नेंट थे या मैलिग्नेंट थे या एडवांस स्टेज के थे. तो इट इज जस्ट हम्बल प्रेजेंटेशन जस्ट टू हाईलाइट द इंपॉर्टेंस ऑफ कैंसर रजिस्ट्री. नेक्स्ट प्लीज. अच्छा इसमें जो इम्पोर्टेंट चीज़ है ना कि उसमें सबसे पहले तो कैंसर सुनना ऑब्वियसली किसी भी स्पेशलिटी का हो उसका एक अपना ही फेयर है, अपना ही खौफ है. बट कैंसर इन फीमेल स्पेशली दैट्स गायनेकोलॉजिकल कैंसर इसके साथ ना मिथ्स भी बहुत सी हैं. बिकॉज जेनिटल ट्रैक्ट कैंसर, गायनेकोलॉजिकल कैंसर रिलेशन टू रिप्रोडक्टिव हेल्थ इसकी वो भी कोरिलेशन है. लाइक इफ द कैंसर इज डायग्नोज इन रिप्रोडक्टिव ईयर्स तो उसमें ये होगा कि उसकी रिप्रोडक्टिव जो कैपेसिटी है वो खत्म हो जाएगी या नहीं होगी, उसकी अगर फैमिली पेयरिंग कैपेसिटी क्या होगी. मैडम नौरीन यहाँ पर हैं, शी हैज वर्कड अ लॉट फॉर द कैंसर्स एंड स्पेशली फॉर द सर्वाइकल कैंसर. तो मैडम आई एम श्योर अपने टॉक में इस बात पर फोकस भी करेंगी कि जो हमारे कुछ स्पेशलिटी से ऐसा कैंसर है जो कि अगर अर्ली डायग्नोज हो तो दैट इज क्योरेबल, बल्कि दैट इज डायग्नोज एट प्री कैंसरस स्टेज. और क्या है उसके डायग्नोसिस में इट इज जस्ट नॉट 100 रुपीज़, इट इज जस्ट फ्यू रुपीज़. एक फ्यू रुपीज़ में अगर उसका प्री कैंसर स्टेज पे डायग्नोसिस हो जाए तो बहुत से कैंसर बच सकते हैं. और सेकेंड जो है ना हमारे बहुत से हमारे कैंसर के साथ मिथ्स भी रिलेटेड है. लाइक मतलब प्रैप्स में कितनी सिंपल सी चीज़ है लेकिन क्या अच्छा डॉक्टर इसमें बचत आने में नुकसान नहीं पड़ जाएगा. वेरी सिंपल, आप करवा लें. क्यों करवा लें? बिकॉज उसकी अवेयरनेस नहीं है. सेकेंड हमारे कुछ ऐसे कैंसर गायनेकोलॉजिकल पोस्ट मेनोपॉजल ब्लीडिंग के कैंसर्स हैं. अब उसके साथ एंडोमेट्रियल कैंसर में इवन की पढ़ी लिखी फैमिली ने पिछले दिनों एक ग्रैंड मदर ऑफ डॉक्टर्स, घर में 4 डॉक्टर्स थे, ग्रैंड मदर उनमें बच्चों का कोई ऐसे कोई कसूर नहीं था. वो दादू को लेके हैं विद एडवांस्ड स्टेज. तो पता चला कि दादू को पिछले 4 साल से शी वाज विद अ पोस्ट मेनोपॉजल डिस्चार्ज, फॉल स्वेलिंग डिस्चार्ज एंड इवन शी यूज्ड टू वॉश हर क्लोथ्स इन द वॉशरूम. वो अपने कपड़े खुद ही बाथरूम में धोती थी कि किसी को पता ना चले. तो उसको रिलेट क्या करती थी? रिलेट करती थी कि मैं ना गर्म चीज़ें खाती हूँ, मैं जिस दिन गर्म चीज़ें खा लूँ. फिर आहिस्ता आहिस्ता ये हुआ कि उन्होंने अपना इवन कि मीट इंटेक भी बंद कर दिया. पहले वो शुरू हुई छुआरों से कि शायद मैंने छुआरे खाए थे इसलिए मुझे दोबारा ब्लीडिंग शुरू हो गई. फिर वो शुरू होते होते गर्म की थी. डॉक्टर मैं ना बार बार यूरिन आता है वॉशरूम में, मैंने पानी कम कर दिया, मुझे जिसम में गर्मी हो गई है तो दोबारा से. एक वेरी मिथ और इवन के पढ़े लिखे लोगों में कि शर्म में नहीं बताते बिकॉज एट ओल्ड एज लाइक अगर एक 60 ईयर्स या 65 ईयर्स में हैं, बेटियां ब्याह के अपने घर चली गई, बहुएं भी बुरी नहीं घर में, लेकिन इट इज़ जस्ट अ बैरियर कि अगर मैं बहू को बताऊंगी वो क्या कहेगी कि इस टेंशन कैचिंग या दोबारा से जवान हो रही हैं। इनके ये बड़े कॉमन लफ्ज़ हैं कि जो हमें इस आउटडोर में भी और स्पेशली पढ़े लिखों में भी ये लफ्ज़ सुनने में है कि जी मैं तो शर्म में नहीं बताया, क्या कहेंगे कि दोबारा से अम्मा जवान हो रही है, अम्मा का दोबारा से साइकिल शुरू हो गया है। सो दैट लाइक देयर इट इज़ द हाइट टाइम कि जहाँ पे हम जैसे ब्रेस्ट कैंसर के एक अवेयरनेस प्रोग्राम शुरू हुए थे, इसी तरह जो जनरल ट्रैक कैंसर्स हैं उनके हम अवेयरनेस प्रोग्राम या रजिस्ट्री उसको अब स्टार्ट करें। और इम्पोर्टेंस मैंने बता दी कि बिकॉज इसमें जो रेजिस्ट्री है उसमें हमारा फोकस टॉपिक है दैट इज वी टॉक अबाउट द प्रिवेंशन, स्क्रीनिंग एंड ट्रीटमेंट। नेक्स्ट प्लीज। और पाकिस्तान में अब हम आ जाते हैं फोकसिंग ऑन सर्वाइकल कैंसर, बिकॉज ये सबसे वो मासूम कैंसर खुदा ना खास्ता ये है प्री कैंसर स्टेज पे डायग्नोज हो जाते हैं विद अ वेरी सिंपल एक एग्जामिनेशन टेस्ट, उसमें से पैप्समेयर के बाद उसकी साइटोलॉजी रिक्वेस्टेड है या उसके डिफरेंट और मेथड्स हैं। लेकिन इसमें जो इम्पोर्टेंट चीज़ है दैट इज अगर ये हो जाता प्री कैंसर स्टेज पे, उससे पहले करके हम स्क्रीनिंग प्रोग्राम पे चले जाएँ तो जिस तरह सादा सी पोलियो की वैक्सीन है, जैसे दूसरी वैक्सीन हम कर रहे हैं, MMR वैक्सीन कर रहे हैं, टाइफाइड वैक्सीन है, फ्लू है, कोविड की वैक्सीन है, वैसे भी वैक्सीन का जो वर्ड है वो बहुत पॉपुलर कर दिया है। तो इवन की HPV वैक्सीन जो है ना दैट कैन बी इंक्लूडेड इन द प्रोग्राम, लेकिन वो कब इंक्लूड होगी व्हेन विच विल बी एविडेंस बेस्ड कि इसकी वाकई ज़रूरत भी है कि कितने कैंसर का बर्डन कितना है और उस बर्डन को बचाया कैसे जा सकता है। नेक्स्ट। मॉर्टेलिटी के स्टैट्स हैं, लेकिन स्टैट्स वही हैं कि जैसे जो एक स्टडी कितने एरिया में हो गई, ये कोई बहुत अगर हम कहें कि नेशनल स्टैट्स हैं और बिल्कुल एक्यूरेट तो आई डाउट, क्योंकि बहुत से अगर मुझे कोई कहे कि स्टैट्स आ रहे हैं और यहाँ पे नेशनल स्टैट्स हैं, डेफिनेटली बीइंग रिस्पांसिबल पर्सन फॉर मोर देन दैट जैकेट में मैंने अपने स्टैट्स अपनी यूनिवर्सिटी के कभी किसी को नहीं शेयर किया। तो सो दैट ये जो स्टैट्स हैं डेफिनेटली वी ट्रस्ट दी स्टैट्स, लेकिन ये आई एम श्योर कि ये उन्हीं जगहों के हैं जहाँ पे स्टडीज कैरी हो रही है। नेक्स्ट प्लीज। यहाँ पे ये है, ये जो सर्वे से पहले पिक्चर है जस्ट ऑन दिस क्वार्टर, ये क्या है, इसमें भी वेरी नेचुरली है, इसमें भी जस्ट टॉपिक, इसमें भी जस्ट लाइक इन्फ्लुएंस सर्वेस, लेकिन यहाँ पे अगर पैप्समेयर हो जाए और पैप्समेयर के बाद उसकी फर्दर जो इन्वेस्टिगेशंस हैं अगर उसके फर्दर टेस्ट हो जाए तो यहीं पे काम रुक जाएगा, ठीक है। लेकिन उसके बाद हमारे पास मोस्ट ऑफ टाइम पेशेंट्स आते हैं ये इतने बड़े बल्कि इससे भी ज़्यादा बड़े मैच के साथ, ठीक है। मैच जो है इन्फ्लेटेड, पिछले दिनों मैंने एक पेशेंट देखा यहीं आउटडोर में कि देयर वाज नो प्लेस इन द वजाइना, कि वो पेशेंट को क्या था और शी जस्ट वो यूनिट फ्रीक्वेंसी के साथ वो जब उसको इतनी फ्रीक्वेंसी हो गई शी वाज अनएबल टू होल्ड क्या जी ब्लीडिंग। डॉक्टर साहब वो तो मैं पोस्ट वाइटल ब्लीडिंग जो है वो एक बड़े कॉमन अर्लीस्ट प्रेजेंटेशन हो सकती है इसकी, तो कहती है डॉक्टर मैं तो बड़े अरसे से बेवा हूँ तो मुझे तो नहीं पता इस बात का, ब्लीडिंग में शर्म में बताती नहीं थी कि अब इलाज कब करवाएगा जाके। और अनलाइकली शी हैज आल्सो द फाइब्रोइड यूट्रस, तो उसको फाइब्रोइड के साथ वो शी यूज्ड टू गो टू वन और अदर फैसिलिटी, उन्होंने क्या किया अल्ट्रासाउंड पे, जो नॉन टच टेक्निक वाली बात है ना कि क्लिनिकल एग्जामिनेशन नहीं किया, अल्ट्रासाउंड पे फाइब्रोइड हो गया, उसका फाइब्रोइड था सब निकोजल, वो उसके साथ रिलेट करते रहे व्हेन द पेशेंट प्रेजेंटेड विद, और फाइब्रोइड का साइज उसका छोटा था 3 सेंटीमीटर का, लेकिन चलो आप कंजर्वेटिव चल जाओ। ड्यूरिंग मेंस्ट्रुएशन शी यूज्ड टू टेक क्या लेती थी कि वो अपनी मेडिकल ट्रीटमेंट ले लेती थी, कांस्टेंट फोर्थ खा के चलो जी ब्लीडिंग कम हो गई, एंड शी प्रेजेंटेड विद फ्रीक्वेंसी ऑफ यूरिन कि मैं यूरिन होल्ड ही नहीं कर सकती, एंड द मोस्ट ऑफ द पार्ट ऑफ द वजाइना वाज फिल्ड विद कैंसर। इससे भी आगे पेशेंट जो है टांग के, डॉक्टर साहब टांग में बड़ी सख्त दर्द निकली है, टांग में बड़ी सख्त दर्द निकली है, तो वहाँ पे ये वाली जो है लिम्फ एडिमा के साथ कि अनएबल टू वॉक, एजेड पेशेंट अनएबल टू वॉक, तो पता चला क्या जब डायग्नोज हुआ। अब सिर्फ ये नहीं कि अगर लिम्फ एडिमा किडनी का पेशेंट आ जाए तो हम ये फोकस ना करेंगे बाकी हिस्ट्री क्या थी, तो डायग्नोज कैसे हुआ, डायग्नोज हुआ पता चला वो तो सर्विस से पेशेंट के शी वाज जस्ट विद अ मेटास्टेसिस एक्सटेंसिव विद द pelvis। नेक्स्ट प्लीज। ये इतनी सी वो मैं अपनी स्पेशलिटी की रिव्यू में यहाँ बैठूँ काफी, तो ये टेंशन ना दिया करो, इतनी सी यूट्रस है उसके साथ 2 ओवरीज हैं, टोटल जो कॉम्प्लेक्स है कितना है, यूट्रस का साइज है 7 into 5 into 2.5 सेंटीमीटर, ओवरीज का साइज है 3 into 2 into 1 सेंटीमीटर। तो मैं कहा करता हूँ टोटल 10 सेंटीमीटर की टेंशन ना क्या करो, उसको गौर से देख लिया करो, उस 10 सेंटीमीटर में गाइनी में सब कुछ डायग्नोज हो जाता है, ठीक है। उसमें ये है कि इतना सा है बट इट्स नॉट इवन अनकॉमन कि कुछ पेशेंट्स प्रेजेंटली फिस्टुला के साथ करते हैं। They are this with a continuous dribbling, तो पता क्या चला, because cervix के साथ अगर वेंटिलेटर लिप से है वो इन्वेट किया ब्लैडर में और डायरेक्टली पेशेंट प्रेजेंट्स विद हेमोटोनिया। ये लोग सब पेशाब कर रहे हो, पहले ब्लीडिंग जो है मुझे जैसी हो रही थी, हैवी हो रही थी, पोस्ट मेंस्ट्रुअल पोस्ट कॉइटल, लेकिन अब यूरिन में पास कर रहे हो तो मुझे ब्लीडिंग शुरू हो रही है, दैट इज विद द ज़ाइगोजेनल फिस्टुला। नेक्स्ट प्लीज। तो ये जो हमने अभी बात की थी कंसोलिडेटेड गायनोकोलॉजिकल, इसकी कोई ऐसी अभी रजिस्ट्री नहीं है। नेक्स्ट प्लीज। लेकिन इसमें इंपॉर्टेंट चीज़ ये कह रहा हूँ कि रजिस्ट्री अब स्टार्ट हो चुकी है। एक माह पहले बेसिकली द हेल्थ सर्विसेज अकेडमी इस्लामाबाद इन कोलैबोरेशन विद डिफरेंट ऑर्गेनाइजेशंस, उन्होंने पूरे पाकिस्तान में अपनी कैंसर रजिस्ट्री लॉन्च की है। और वी वर प्रिविलेज्ड के जो पंजाब में जो प्रेजेंटेशन है दैट्स फ्रॉम फातिमा जनाब मेडिकल यूनिवर्सिटी, हमने अपनी रजिस्ट्री जो लॉन्च हुई है और पूरे चारों लोगों में उनका एक प्रोग्राम था और एक इंस्टीट्यूशन लिया था, इसका हमने प्रोग्राम लॉन्च किया। और उसके बाद वो प्रोग्राम बल्कि उस दिन हमें एफजे के अलावा आउटसाइड द कैंपस रखना पड़ा था, सामने टावर इनॉग्रेट हो रहा था, बिकॉज ऑफ सिक्योरिटी रीजन क्लियरेंस नहीं हो सकी थी, तो इसलिए फिर हमने अपना प्रोग्राम बाहर रख के, लेकिन एट द सेम डेज वाज लॉन्च और उसमें उनकी ऐप बनी है, सून दैट ऐप विल बी शेयर्ड नेशनली। और उसमें बड़ा एक सिंपल सा परफॉर्मा था जस्ट टू मेंटेन द डाटा, लेकिन उसमें स्ट्रेंथ ये थी कि वी स्टार्टेड फ्रॉम, हमने उसका एक किस्म का एनालिसिस स्वॉट एनालिसिस करके और रजिस्ट्री लॉन्च की है। उसमें पूरे पंजाब तमाम मेडिकल कॉलेजेस के हेड ऑफ डिपार्टमेंट्स, गायनी के हेड ऑफ डिपार्टमेंट्स, उनको जो इनवाइट किया था इन इनिशियल फेज इट वाज फ्रॉम पब्लिक सेक्टर। अब वो जब लॉन्च होगी देन वी विल इनवाइट द प्राइवेट सेक्टर आल्सो, बिकॉज जो हमारा हम सबको पता है कि जो मेडिकल कॉलेजेस हैं, जो हमारे ये मेडिकल जो गवर्नमेंट इंस्टीट्यूशंस हैं वो अपना बर्डन ले रहे हैं डिजीज का, लेकिन प्राइवेट जो है वो भी हम इसी तरह सर्व कर रहे हैं। तो जो सेकंड फेज है उसमें वी विल इन्वॉल्व द प्राइवेट सेक्टर आल्सो। और सोन ये हमारा उसमें जो फर्स्ट वैसे वो जो रजिस्ट्री लॉन्च हो रही है दैट इज द कैंसर रजिस्ट्री लॉन्च, लेकिन उसमें जो मेन डाटा स्टार्ट में फर्स्ट जो होगा डाटा बेटर वो सर्वाइकल कैंसर का है, सो दैट वी कैन जस्ट एनालाइज एंड मेक अ बेस अदर इफ इट इज इट वर्थ टू लॉन्च एंड टू इन्वॉल्व द वैक्सीनेशन प्रोग्राम, कि उस वैक्सीनेशन प्रोग्राम में हम कैंसर को डालें भी या ना डालें, क्योंकि हमने अपना डाटा दिया भी तो आगे बात चलेगी। नेक्स्ट प्लीज। नेक्स्ट ये उसी के उसमें था कि कैसे हमने किया। नेक्स्ट प्लीज। और इसमें ये भी था कि उस वक्त में प्रॉब्लम आ रहा था कि अगर हम उसकी रजिस्ट्री लॉन्च करते हैं प्रोस्पेक्टिव, उसमें इशू होगा, तो वन सजेशन वाज कि इसको रिट्रोस्पेक्टिव, अगर कहीं पे डाटा तो है, जैसे हमसे आज के दिन में अगर आप पूछें कि 1 साल का अपना डाटा दे, डेफिनेटली हमारे पास डाटा है, हमारे पास गायनी में भी डाटा होगा, ओपीडी में भी होगा, हमारे ऑपरेशन थिएटर में और हमारे पैथोलॉजी डिपार्टमेंट में, तो डाटा हमारे पास है। तो उसमें हमने रिट्रोस्पेक्टिव डाटा और फिर प्रोस्पेक्टिव डाटा, उसमें 6 मंथ्स की वो वर्किंग करके देन वी विल जस्ट अगेन वी विल हैव द रिव्यू मीटिंग और फिर प्रॉपर एक रजिस्ट्री लॉन्च करेंगे। तो थैंक यू वेरी मच। उनका अपने कार्ड भी मेरे आगे रख दिए, तो आई एम श्योर कि आई एम डन इन टाइम।
Very much, Madam. You are very innovative information, and we are happy that you answered. Our next speaker is Professor Dr. Shahid Parvez. He is Professor and Consultant Histopathologist, Department of Pathology and Laboratory Medicine, Aga Khan University Hospital. He is Counselor at College of Physicians and Surgeons, Pakistan for last 4 years, for till like 2023. He is Country Advisor and Senior Examiner for Royal College of Pathologists, UK, and he is Founder President of IAD Pakistan Division, Histopathology and Cytology Society of Pakistan. He is currently President of Pakistan Association of Pathologists, and he is Chair of Karachi Cancer Registry as well. He is Editor of Atlas of Diagnostics and Preventive Histopathology and Editor of Journal of College of Physicians and Surgeons, Pakistan. Sir, please come.
Thank you very much, organizers, in particular, Dr. Shafiq Gill, who was our trainee several years ago at Aga Khan University Hospital, and his spouse was also doing residency at the same time. They got married, moved to the UK, and they both are highly accomplished pathologists, histopathologists there. And the Madina Medical University for giving me this opportunity. I am a histopathologist at Arafan, and this is my 32nd year. I joined way back in 1991. And we do a lot of pathology. We receive something like 100,000 biopsies per year, because not only from AKU but the rest of the country as well. So I am also chair Karachi Cancer Registry and co-chair National Cancer Registry. And National Cancer Registry not only exists, but we have analyzed data of the last 5 years, and it is under write-up and publication. So let's start with why cancer registries are important. To collect the cancer incidence data to provide essential information to healthcare providers, government researchers, to identify major risk factors in a population based on their lifestyle. Because we know that though cancer is due to, strictly speaking, due to DNA damage or epigenetic factors, the lifestyle, the environmental factors are very important. That's why the cancer incidence in Karachi may be very different from Lahore, Quetta, KP, Afghanistan, so even within a country, right? Cancer registries are the foremost requirement for cancer control programs in any country, like prevention and screening. Prioritize government policies and fund allocation, and ultimately reduce the burden of cancer. So Karachi Cancer Registry was revived after a gap of about 10 years. In fact, the first population-based cancer registry in Pakistan was started in 90s by late Yasmin Gurgadi, who was a pathologist in a public sector university, but also, a part-time lecturer at Arafan University because of this reason. And that was the only source of population-based cancer data which was used by IRWH. And I was remained part all along, and it was going very well until maybe 2007 or so. And then one day she didn't get up. She passed away. So although she was a very hard-working, meticulous lady, but she was a very private person. She didn't used to share, with others. So with that, as happens, everything fell apart. And that was the time when Shaukat Khanam took the initiative, right? With the start of Shaukat Khanam Cancer Registry, and then this so-called Punjab Cancer Registry, but Punjab Cancer Registry governs only Lahore major institutions and some institutions outside Lahore. And currently, the IRWH uses the Punjab Cancer Registry data, which is on the Globocam, which was shown by Dr. Shahzad, and extrapolate that for Pakistan, right? Before that, it used to be the Karachi Cancer Registry, and now again, Karachi Cancer Registry may be part of the IR data. So it is a part of National Cancer Registry established under the Ministry of National Health Services Regulations and Coordination, Islamabad. And we started collection of cancer data from 2017 and invited all cancer diagnosing and treating hospitals to send data on voluntary basis. Unfortunately, cancer is not a reportable disease like dengue, like COVID. Otherwise, things will be very easy. If it's made mandatory, they have to report it, and only then, we will have the real essence of what's going on. So this is our city, Karachi. Pakistan is the 5th most populous country in the world, with a population of about 225 million, and Karachi, again, one of the most populous cities in the world, with a population of at least 20 million. And in the one of the, if you see any statistics, it comes in the top 10 most populous countries. And lots of, about 40% of the population lives in the slums, in Kachi Abadis and so on, and all kinds of environmental, lifestyle, genetic factors are playing their role and havoc in Karachi. So participating centers include, we are the major contributor, Khan University Hospital, JPMC, Indus Hospital, Dow University, Ziauddin, Zainab Panjwani, Baghai, and so on. So this was the 3 years data which we published in 2020, and now the 5-year data of Karachi Cancer Registry is collected and analyzed, that is from 2017 till the end of 2021, and it's analyzed and it is under publication. So I will show you the 5-year Karachi Cancer Registry data, right? So if we combine both males and females, the cancer is more common in females. It's because of the breast, because breast is so common, right? So that's why 51% cancers in females and 49% in males, right? This is if we combine both. Age is standardized. If we combine both genders, breast is going through the roof, right? Very common, obviously, as you said, in Asia, one of the highest in Asia. If you exclude the Ashkenazi Jews, the European origin Jews, for example, Einstein was an Ashkenazi Jew, we have one of the highest, and that's a separate topic, that why we have breast cancer is so common, and followed by oral cavity, ovary, esophagus, and so on. This is combined, right? Now, this is males. In Karachi males, oral cavity cancer is the most common cancer. And you see, where is the lung? This is the lung. I think about 10-15 years ago, lung cancer used to be the most common cancer, right? Now somehow the chewing, if you go to Karachi, the labor class and that blue collar, everyone is chewing, and pan gutka, pan and chalia has been in the subcontinent for centuries, but now some very dubious products, what they call gutka and manipuri, these are some very addictive, ready-made sachet forms available, highly addictive. They contain tobacco, lime, and God knows what, and they are highly carcinogenic. And somehow, still the society is more tolerant to chewing than smoking, because we can't smoke in aeroplanes for a long time. But the other day when I was in the plane, the guy sitting next to me was comfortably chewing. So it has very much replaced smoking. And as per our registry, 80% of the oral cancer patients are chewers. So in other words, at least 3/4 of oral cancers are preventable, right? So that's a very important message. So this is female. Okay. I think I have somehow that combined slide is skipped. So this is female breast, followed by oral cavity, and these are males, right? And in children and adolescents, because these mostly have the genetic, mutations, and environmental factors are not that important. So largely worldwide, the 3 most common cancers from group of cancers are hematolymphoid like leukemias and lymphomas, brain tumors like medulloblastoma, and bone and soft tissue tumors like osteosarcoma, Ewing sarcoma, and so on, right? And this is what Dr. Shahzad was showing. This is from the Globacam, IRWHO, and if you combine both genders, obviously the breast cancer is the most common cancer, followed by the oral cavity and so on, right? Now, I will, show you this a little bit slightly change as something very intimidating. This is from the Dawn newspaper. It appeared in the Dawn and white coverage that most cancer cases are caused by bad luck. What we mean by bad luck? I mean, luck plays an important role. Starting from the birth, we don't choose our parents, So, if I think that I am a professor and I am earning 10 times or 20 times more than my driver, so I'm 20 times smarter, that is totally incorrect. My driver may be much smarter than me. It's just the biological good luck that I was born in a family, particularly in a country like Pakistan, where there is so much disparity, that my parents were able to educate me, right? So, this was based on the paper which was published in the Science from Johns Hopkins University, right? The bad luck of cancer. So, a little bit on that. There are many cancers which comes out of blue and there are no risk factors. Because we always try to associate that if this guy has developed pancreatic cancer or ovarian cancer or prostate cancer, we always look, why me? I have been very healthy lifestyle, but there are several cancers which are just out of bad luck mutations, right? And for example, brain tumors, no risk factors. Pancreatic cancer, no risk factors, right? Ovarian cancer, no risk factors. So how we explain that? So actually mutations that can lead to cancer can be caused during a person's lifetime by environmental and lifestyle factors such as cigarette smoke. However, they may also be inherited or they may happen by chance, right? So these chance mutations occur because errors can be made when a cell copies and divides its DNA. As the replication process isn't perfect. All the time we are growing, The old cells are perishing, new cells are coming up from the stem cells, right? So cancer risk is most strongly associated with how quickly and times specialized cells called stem cells, They replicate which they perish tissues with new cells as others becomes old and damaged. So actually, before a cell divides, it double cells DNA. Then 50% of the genetic material goes into one cell, 50% into the other. But during, it's like a photocopying. If some error is made but just by chance, that's mutation, and that may lead to its consequences. That's the biological bad luck, right? So as a result, investigators predict that mutations in 2 out of 3 cancers are due to bad luck, right? Which they define as the random genetic mistakes that occur naturally in cells as they divide and may lead to cancer. So actually, I have already given that 3 minutes are left, there is not much time. However, this was a very robust study which was published in journals like Science, the high impact journals from Johns Hopkins, and eventually people realized that this has weightage and this appears to be true. So I won't go, however, in this mathematical models, all 17 different cancer types recorded in the IR database for which stem cell data was available was used for this analysis. And that how the cancers can start in stem cells. So I won't go into the detail for sake of time. However, the stem cells all the time they are dividing, and if just they make a random error in photocopying, that may lead to its consequences, right? So actually, this is, I think, a very important slide, and what they have shown that, for instance, in large bowel, during lifetime, the divisions of stem cells are about 10 to the 13 compared to, say, stem cells in duodenum. So, more divisions, more likely to make an error. So, we know that colorectal adenocarcinomas are much more common than duodenal adenocarcinomas, right? On an average, an adult have about 130 trillion cells, right? So you see, hereditary, very weak in adult cancers. Environmental, obviously, lung because of the smoking, right? Stomach, maybe Helicobacter pylori, right? Some smoking and other things. Normal, you see, replicative, the random error, making a good percentage of. So blessing in disguise is that cancer in which 50% of the mutations are due to random error can still be preventable, because cancer requires more than one mutation, right? So if with a healthy lifestyle, if some bad luck happens, however, if your lifestyle is healthy, there are more chances that you won't have a second mutation leading to cancer, and then those with healthy lifestyle will have more chance to avoid cancer, right? So oral cancer is so common, in Pakistan, starting here and coming out, surgeries, the whole tongue is chopped off and so on. Neck is full because of the metastasis at a advanced stage. So conclusion, oral cancer, a largely preventable cancer, is the leading cancer in Karachi adult males, while in females, breast cancer is the leading cause. Remember that breast cancer is also largely a non-preventable cancer, right? So, followed by oral cancer. In children and adolescents, like the rest of the world, bone leukemia and brain malignancies are most common. Colorectal is now both in males and females on the rise in the top 5 cancers in Pakistan. Liver cancer is also, the expectancy is so poor because of hepatitis B and C in our population. So, those cancers which are not preventable, the only chance is to detect early by screening, like mammography in breast cancer, right? So thank you for your attention.
The next presentation, Professor Farooq Rahman.
That's why I want to tell a few points about it. Tumor district was there in Lahore for many years. When I was training at there was a tumor district program run by the head of oncology department, Professor Shahriar. But that was a primitive time. In 2004, we pathologists, Faisal Sultan, Shaukat Khanam, he is my class fellow and friend, that's why Shaila Niazi from K, and from make a plan of cancer history Lahore, which started with a common point which we said that wherever a cancer person comes should register his ID card number so that we should not have an overlap. So a performer was made. Then the point was raised that most of the hospitals in Lahore are the tertiary care hospitals. And we have the population coming from far off all the Punjab. So we changed the name Punjab Cancer Registry. FJ is a part of it for so many years. It's not started now. Pathology department, if Professor Mirza is here, is regularly entering the tumors into that registry. We have performance with us. Any diagnosis of cancer, a performer is filled and is deposited to the center of point, which is Shaukat Khanam. and incentives are given. We even in our private labs, in our private hospitals, we fill that performance and send it to the central area where the data can be collected by all the founder members. So that was just a clarification which I want to make. Okay, we are a part of it for so many years. I'm not, the other things we'll be discussing with the question and answers. Thank you very much.
Gynecologist and obstetrician at Doctors Hospital and Mid-City Hospital. She's member expert roster for global strategy against cervical cancer WHO, and she's member WHO guideline development group for living recommendations and systematic reviews on screening and treatment of to prevent cervical cancer. She's founder and president Girls and Women Health Initiative, and she's clinical lead and Fistula Challenge Punjab. She'll talk about cervical cancer screening in Pakistan. Madam, please come.
For giving me this opportunity to come and talk to you about something which is extremely close to my heart. और जैसे आप लोग पीछे बच्चे बैठे हुए हो तो जब शुरू करते हैं आप अपना सफ़र मेडिकल का और उसके बाद हाउस जॉब का, तो उस वक्त द स्पिरिट्स आर रियली हाई. और मेरी एफिलिएशन या एसोसिएशन विद सर्वाइकल कैंसर गोज बैक टू 1987 व्हेन आई स्टार्टेड माय हाउस जॉब. और मेरी मैडम फ़खर अल्लाह ताला बख्शे उनको, उनके साथ आई वाज वर्किंग और प्राइवेट वार्ड में मेरी ड्यूटी लगी थी. और उस रूम में एक माँ थी, यंग गर्ल, मेहर था उसका नाम. शी केम फ्रॉम अ वेरी गुड नोन फैमिली, रिच फैमिली फ्रॉम मुल्तान. और उसके दो छोटे छोटे से बच्चे थे, मेरा ख्याल 4 साल और 3 साल या इस तरह से. और जिस तरह से प्रोफेसर साहिबा बता रही थी, डॉक्टर जोहरा, कि she had this huge mass in the vagina which was almost coming out at the introitus. और रोज़ उसकी मुझे ड्रेसिंग करना होती थी और बाकायदा मास्क वगैरह पहन के, और कमरे में फूल भी थे और डिओड्रेंट्स भी थे और सब कुछ था, लेकिन देयर वाज अ टेरिबल स्मेल. और उसके दो छोटे छोटे बच्चे. एंड शी वाज द फर्स्ट पेशेंट दैट आई सॉ डाइंग, एंड शी डाइड ऑफ सर्वाइकल कैंसर. उसके बाद 92 में अल्लाह की मेहरबानी से, मेरे पेरेंट्स की मेहरबानी से, आई वेंट टू इंग्लैंड. और खुशकिस्मती से आई स्टार्टेड वर्किंग विद प्रोफेसर फ्रैंक शार्ट, हु वाज द अथॉरिटी इन colposcopy at that time, and he had set up the cancer screening program in Africa and England. तो एक खातून आई वहाँ पे, जैसे टैटूज और इस तरह से, जिनको हम सो कॉल्ड जरा हाई रिस्क पेशेंट्स देखते हैं. And he did a loop cone on her in the clinic, and he said कि इनका CIN bordering to in situ था, and I have done a loop excision and she is going to be fine. So उस वक्त मुझे उसी बच्ची का ख्याल आया जिसको मैंने बहुत हेल्पलेसली और पेन में I saw her dying in Lady Wellington, and then I decided कि अल्लाह करे कि if I'm able to पढ़ लिख लूँ तो वापस जाके I'm going to try and establish a cervical cancer screening program. और अब तकरीबन इस बात को भी 3 decades हो गए. I've been back since 1999, and I hope with people like yourself sitting in the front row and more OBGYNs interested into it, we are able to actually do that, because अगर एक भी जान बचती है तो गोया आपने सारी इंसानियत की जान बचाई. I think it is just about time that we start the cervical cancer screening program. इसलिए कि बहुत सारे तो इसी चक्कर में लग गए कि गवर्नमेंट मानती नहीं थी कि cervical cancer is a problem in Pakistan. And we'll discuss further कि क्या मसला है. लेकिन अगर आप में से किसी ने भी कभी कोई देखा हो cervical cancer का केस, तो it's a very slow growing cancer. Symptoms बहुत लेट आते हैं और सबसे बड़ा प्रॉब्लम ये है कि सिम्टम्स उस वक्त आते हैं जब, जैसे मैडम बता रही थी, कि साइड्स पे पेल्विक साइड वॉल तक एक्सटेंशन हो चुकी होती है, नर्व्स और आपके यूरेटर्स इन्वॉल्व हो चुके होते हैं. इट्स अ वेरी स्लो, पेनफुल एंड यूरेमिक डेथ. ऑल्दो सर्वाइकल कैंसर इज ऑलमोस्ट इंटायरली प्रिवेंटेबल, फिर भी सारी दुनिया में लास्ट ईयर तकरीबन 6 लाख खवातीन को हुआ सर्वाइकल कैंसर. And almost half of them died. और इनमें से 80% die in countries like ours. और पाकिस्तान हर चीज में हमें नीचे नजर आता है. जो हमारे जेंडर डेवलपमेंट इंडेक्स है, हम 143rd में हैं 145 में से, लेकिन सर्वाइकल कैंसर की हम टॉप 7 कंट्रीज में हैं इन द वर्ल्ड. You can't probably see, but 7,311 deaths were reported. तो आप इसको करेंगे? इसी से Now, जैसे ब्रेस्ट कैंसर की बात की डॉक्टर साहब ने कि इट इज नॉट entirely preventable, but this is very different for cervical cancer. It's a slow growing tumor. It will take roughly 10 to 15 years from developing. जो आपको प्रोफेसर साहिबा ने तस्वीर दिखाई, हमें पता है कि ह्यूमन पैपिलोमा वायरस से होता है. 99% ऑफ सर्वाइकल कैंसर्स है ह्यूमन पैपिलोमा वायरस, probably 16, थोड़ा सा 18, 31, 55, 58. और इस एंड से शुरू होने से लेके अगले एंड तक जाने में 10 से 15 साल लग जाते हैं. तो वी हैव अ ह्यूज विंडो ऑफ अपॉर्चुनिटी. सेंटर में जो स्लाइड है वो आपकी एचपीवी से इन्फेक्टेड सर्विक्स है, लेफ्ट पे नॉर्मल है और राइट पे व्हेन देयर इज नो एनाटॉमी विजिबल एनीमोर एंड इट्स जस्ट अ मैस. सो थ्योरेटिकली सर्वाइकल कैंसर को तो खत्म हो जाना चाहिए. हमारे पास 10 से 15 साल हैं इसको डायग्नोज करने के लिए. खुद ही चेंज होती जा रही है, आप इसमें थोड़ा सा जरा देख लें. सो डेवलप्ड कंट्रीज में क्या हो रहा है कि सर्वाइकल कैंसर स्क्रीनिंग प्रोग्राम है. अभी डॉक्टर शफीक विल प्रोबेबली टॉक अबाउट इट. तो स्क्रीनिंग वो टेस्ट है जो आप सारी पॉपुलेशन पे करते हैं विदाउट एनी रिस्क फैक्टर्स. सो उस वक्त स्क्रीनिंग नहीं होती जिस वक्त पेशेंट को पोस्ट कॉइटल ब्लीडिंग और इंटरमेंस्ट्रुअल ब्लीडिंग और यूरिनिया शुरू हो जाता है. उस वक्त द कैंसर इज ऑलरेडी देयर. स्क्रीनिंग इज अ टेस्ट व्हिच इज डन फॉर एवरीवन टू पिक अप अ डिजीज जिसका के प्री कैंसरस फेज है, या जैसे डायबिटीज है प्री डायबिटिक फेज, एंड सर्वाइकल कैंसर फिट्स इनटू दैट. अब ज्यादा जगह पे साइटोलॉजी बेस्ड होती है. लेटली नाउ एचपीवी टेस्टिंग विल प्रोबेबली रिप्लेस दैट. नेक्स्ट प्लीज. सो पैप स्मीयर सिंपल है, पेन नहीं होती पेशेंट को, क्लिनिक में आप कर सकते हो. आयर स्पेचुलास भी अवेलेबल है, लैब्स भी हैं जो कर रही हैं. अब लिक्विड बेस्ड साइटोलॉजी आ गई है. The problem is कि जो अफोर्ड कर सकते हैं वो तो कर लेते हैं, but what is going to happen with 75% of our population जो ना तो अफोर्ड कर सकते हैं, और वही औरतें जो हाई रिस्क है सर्वाइकल कैंसर के लिए because of their poor reproductive health, because of repeated infections, because of repeated pregnancies, because of repeated abortions, and their husbands working either out of country or जिस तरह ये ट्रक ड्राइवर्स हैं. तो रिस्क फैक्टर्स हमारे पाकिस्तान में सारे मौजूद हैं जो कि बाहर के मुल्कों में मौजूद है. इवन स्मोकिंग, टबैको और HIV. अब आप सब लोगों ने सुना होगा कि इट्स नॉट लाइक एन अनयूजुअल डिजीज टू फाइंड हियर. नेक्स्ट प्लीज. सो द हिस्टोपैथोलॉजिस्ट्स आर ऑल सिटिंग हियर एंड दे कैन टेल यू व्हाट अ पैप स्मीयर कैन टेल. नेक्स्ट. इंग्लैंड में, यूरोप में, यूएसए में, ऑस्ट्रेलिया में, हम यहाँ से जब शुरू हुए थे 1971 से 1988 में जब स्क्रीनिंग प्रोग्राम उनका आया, तो देयर इज more than a 50% reduction. But obviously हमारे पास इतने पैसे नहीं है, हमारे पास इतना इंफ्रास्ट्रक्चर नहीं है, तो maybe we cannot do the cytology bit. Next please. So पाकिस्तान में there's an urgent need of screening program. हमारे पास सिर्फ around 2% खवातीन जो हैं उनका कभी भी जिंदगी में एक सर्वाइकल स्क्रीनिंग टेस्ट हुआ है, कभी भी. और usually it's a part of a study. मैंने VIA की स्टडी करनी है तो मैंने 100 औरतों का कर लिया, मैंने पैप स्मीयर की स्टडी करनी है तो 500 औरतों का कर लिया. बट देयर इज नो नेशनल और रीजनल सर्वाइकल कैंसर स्क्रीनिंग प्रोग्राम. और जब हम बात करते हैं सिग्नेटरी होने की, तो हमने SDGs पे भी साइन किया हुआ है, लेकिन आपको पता है कि SDGs में अब सर्वाइकल कैंसर भी शामिल है। सो इट इज़ नॉट अ लग्जरी एनी मोर। जैसे मैटरनल मॉर्टेलिटी इज अ सिग्निफिकेंट इशू, इसी तरह सर्वाइकल कैंसर की डेथ्स और मॉर्बिडिटी जो है, दैट्स ऑल्सो अ सीरियस इशू। नेक्स्ट प्लीज। So the way forward is that we have an integrated approach, सर्वाइकल कैंसर के बारे में बात करें, रिस्क रिडक्शन करें, प्रिवेंशन स्ट्रेटजीज पे बात करें, we should strengthen screening and treatment, सबको इन्वॉल्व करें, और जो मिथ्स और टैबूज हैं in talking about cervical cancer, next please, उनको हम एड्रेस करें। और I think सबसे पहले भी I think डॉक्टर जोहरा ने भी ये बात की थी कि there's a huge body of stigma and taboos and shame in talking about anything related to women. हाँ, आप पीरियड्स के बारे में बात कर लें, आप सैनिटरी प्रोटेक्शन के बारे में बात कर लें, आप रिप्रोडक्टिव हेल्थ के बारे में बात कर लें, फैमिली प्लानिंग के बारे में बात कर लें, अबॉर्शन के बारे में बात कर लें, या आप सर्वाइकल कैंसर स्क्रीनिंग के बारे में बात कर लें। So people don't want to talk about it, but I think it is just about high time that we get rid of these cultural barriers. दूसरा जैसे ये कि कोई अपना रिस्क एक्सेप्ट नहीं कर पाते। कैंसर का क्लिनिक में भी जो खवातीन आती है, अच्छी भली प्लेजेंट हो रही होती है, द मोमेंट यू स्टार्ट मेंशनिंग, अच्छा आपने कभी मैमोग्राम कराया है, आपने कभी पैप स्मेयर कराया है, तो वो नहीं अल्लाह माफ करे, तो वास्तव डॉक्टर साहब हमारे यहाँ कोई हिस्ट्री नहीं है कैंसर की, एज इफ वी थिंक के कोई और होते हैं जिनको कैंसर होता है। सो अपना एक रिस्क एक्सेप्टेंस भी जरूरी है, उसके साथ डाइट के चेंजेस, एक्सरसाइज जैसे पहले बताया गया, और अवेयरनेस रेजिंग जरूरी है। मतलब आप अपना इवन आपको पाकिस्तान के चैनल्स का आपको ये प्रोग्राम देख लें, आधी गायनी तो आपको वो पढ़ा देते हैं, तो क्या पर्दा रह गया बात करने के बारे में। बच्चियों को, खवातीन को इंफॉर्मेशन मिलनी चाहिए। नेक्स्ट प्लीज। सो ये स्लाइड आपने पहले भी देखी है, ग्लोबो कैम की है। खवातीन में गायनेकोलॉजिकल कैंसर्स में सर्वाइकल कैंसर इज द मोस्ट फ्रीक्वेंटली हैपनिंग कैंसर। नेक्स्ट प्लीज। WHO ने अब 2020 में एक बाकायदा सर्वाइकल कैंसर एलिमिनेशन स्ट्रेटजी शुरू की है, ऑफ विच अल्हम्दुलिल्लाह आई एम आल्सो अ मेंबर, और देयर इज प्रोग्रेस बीइंग मेड। हमने इसके ऊपर भी साइन किए हैं। अब देखें इसकी तरफ हम काम क्या करते हैं। नेक्स्ट प्लीज। सो बेसिकली आपने क्या करना है, HPV वैक्सीनेशन की कवरेज बढ़ानी है। मैं भी डॉक्टर साहब से पहले बात कर रही थी कि HPV वैक्सीनेशन कोई 2 सालों के लिए आई थी पाकिस्तान में, एंड देयर वाज अ स्ट्रॉन्ग फार्मास्यूटिकल पुश बिहाइंड इट, मगर वो तकरीबन 12,500 उस वक्त बन रहा था फॉर द 3 इंजेक्शंस, एंड इट वाज नॉट इवन जो 9 वेरिएंट, इट वाज जस्ट अ बाइवेलेंट वैक्सीन, और वो भी अब खत्म हो गई है। So I think we need to address that issue. दूसरा, we need to increase our coverage of pre-cancer screening, and finally जिनको हो जाता है कैंसर, अगर आपने कभी किसी पेशेंट को फॉलो किया who has had cervical cancer which is usually advanced by the time they come, तो उनके अनमोल के चक्कर या शौकत खानम के चक्कर लगाते लगाते वो खानदान जो है ना, मियाँ की भी नौकरी चली जाती है, बच्चों की भी पढ़ाई खत्म हो जाती है, और फिर भी माँ की जान नहीं बचती। नेक्स्ट प्लीज। So 90, 70 or 90 is the target that WHO has given. That 90% girls should be fully vaccinated for HPV vaccine. 70% of women should have at least one screening test by the age of 30. Thank you. Or 90% of the women who have been identified with cancer should be treated appropriately. Next please. ये वही स्लाइड है जो आप देख चुके हो। पिछले साल में 5008 खवातीन को हुआ सर्वाइकल कैंसर, जिसमें से 3200 के करीब वफात पा गई। एंड दिस इज अ डिजीज, प्लीज रिमेंबर, व्हिच इज कंप्लीटली प्रिवेंटेबल, जिसको होना चाहिए ही नहीं है, और हमारी 60% औरतें, 10 में से 6 औरतें विल डाई ऑफ दिस। नेक्स्ट प्लीज। नेक्स्ट। सो वी डोंट हैव अ वैक्सीनेशन, जीरो है हमारा वैक्सीनेशन प्रोग्राम। नेक्स्ट प्लीज। ओके, सो अब हम क्या कर सकते हैं। पैप स्मेयर हम कभी कभी करते हैं, हमारे पास पैसे नहीं है। HPV वैक्सीनेशन हमारे पास है नहीं है, HPV टेस्टिंग भी हमारे पास नहीं है। सो प्रोबेबली VIA visual inspection with acetic acid, one single lifetime screen between 35 and 45 is something that we can achieve. Next please. Next. ओके, सो VIM इज सिंपल, आपने सिरका लेना है 3 to 5% एसिटिक एसिड। क्लिनिक में आप गायनी के लिए जो भी स्पेकुलम एग्जामिनेशन करते हो, जस्ट डैब इट विद एसिटिक एसिड। जहां कैंसर है वहां पे प्रोटीन्स कोएगुलेट हो जाएंगी, आपको थिक वाइट एरिया नजर आएगा एंड यू कैन ट्रीट इट। नेक्स्ट प्लीज, नेक्स्ट। सो ये जो 2 वाइट एरियाज आपको नजर आ रहे हैं, प्लीज पीछे चलेगा। हाँ जी, आई होप यू कैन सी ऊपर वाली स्लाइड में भी, सेंटर में और नीचे वाली स्लाइड में बिटवीन 9 and 12 there is thick acidophile area, जिसका if you are sure it's not cancer, you can just freeze it with cryotherapy. Next please. Next. Okay, this is a manual that I have written for visual inspection with acetic acid and we have run courses. Next please. ये consolidate कर लें please अपना screen and treat. And I would request Professor Zora Khanam and Fatma Jinnah to take an initiative. I have been trying that with King Edward as well. कि आप सिंगल विजिट में खातून को देखें, गायनी का एग्जामिनेशन करें और क्रायो करके भेज दें if she has an abnormal area. Next please. Next. ओके, और दूसरी ये बात है कि आपकी कॉल्पोस्कोपी सर्विसेज डेवलप होनी चाहिए, क्योंकि चाहे आप VIA करो, चाहे आप HPV टेस्टिंग करो, जब भी आएगी पाकिस्तान में जो एबनॉर्मल रिजल्ट है उसको आपने फिर कॉल्पोस्कोप से चेक करना होता है, उसकी बायोप्सी लेनी होती है या लूप करना होता है। नेक्स्ट प्लीज। सो दिस इज द एंटायरिटी ऑफ सेटअप दैट यू नीड, और इसमें से 90% चीजें आपके पास फातिमा जिन्ना में, केई में, हर जगह पे अवेलेबल है। ऑल यू नीड इज अ कॉल्पोस्कोप, यू नीड ट्रेनिंग, थोड़ा सा एसिटिक एसिड, थोड़ी सी ग्लूकोज, आयोडीन, ये लूप सब मिल जाते हैं सियालकोट से। 450 पौने 500 का एक लूप मिल जाता है एंड द वुमन कैन बी गॉटन rid of the risk of cervical cancer once and for all. Next please. And thank you very much for listening, and I hope that this can lead to initiation of a cervical cancer screening program. Thank you very much.
Astonished to know that only 2% of females they are getting screened for cervical cancer. That's really ironic. So with this, we'll move on to our next speaker. We'll play her presentation online here. That's Lisa Shepherd. She is basically a specialist nurse with experience in palliative and end-of-life care in community and acute hospital setting. And she's talking about cancer pain in the palliative patients.
Cancer pain is multifactorial in nature. There are many things that influence our palliative care patients with cancer that affect their pain. In this presentation today, I will briefly speak about types of pain, pain assessments, total pain, and some practical tips to support your everyday practices. In my experience, the common types of pain experienced by our palliative care patients with cancer is acute pain, nociceptive pain, and neuropathic pain. Alongside that, our patients will have other pain issues to include chronic pain. These three types of pain can be very difficult to assess, especially neuropathic pain. The patient may have acute pain, nociceptive pain, and neuropathic pain all at the same time. Part of assessing for pain is to find out what those pains are, how they affect the patient. For example, neuropathic pain is described as burning, stabbing, numbness, tingling, freezing, shooting. There are lots of other words they may use. They may talk about having an ache or a pressure or a squeezing feeling, which is nociceptive pain. If we deal with one pain by say medication, you may find that the neuropathic pain comes out, and often they need a combination of treatments and therapies to get on top of their pain. Next, I would really like to speak to you about pain assessment. This is something I feel really passionate about, and it's really important when looking at pain in our palliative patients, whether at the beginning of their journey and towards the end of their journey and through the whole assessment process. I use this acronym, FJ UHC.
I welcome our worthy Vice Chancellor. Sir is so energetic and so visionary. He always makes such activities possible, and we get the opportunity to learn from such a learned faculty. Thank you so much, sir, for arranging this event for us. And I would invite sir to please come on the stage for a shield distribution. First of all, Dr. Shahid Pervez, sir, please come here.
असल में ना जिस किस्म का कोई बंदा आए तो वो शीट से पहले तकरीर करना चाहता है। तकरीर के लिए तो बुलाया नहीं आपने।
सर प्लीज
ये आप बैठे हैं सर, तकरीर मुझे कर लेने दें। आजा आजा। और दूसरा आई एम वेरी हैप्पी कि फातिमा जरा मेडिकल यूनिवर्सिटी में जो आज का इवेंट जा रहा है, एटलीस्ट आई हैव बीन टू वेरियस इंस्टीट्यूशन ड्यूरिंग लास्ट 30 इयर्स, तो इतनी खूबसूरती के अंदाज में 4 पैरेलल हॉल में गुड अटेंडेंस के साथ, अच्छी ऑर्गेनाइजेशन के साथ, आई थिंक शायद शायद परवेज साहब माशाल्लाह ही इज द इंटरनेशनल स्पीकर और शफीक गिल जो है ये स्टूडेंट यूनिट के प्रेसिडेंट हैं एडवर्ड के। जब मैं उस वक्त तहसील रजिस्ट्रार था, ही वाज द एक्टिंग प्रेसिडेंट ऑफ स्टूडेंट यूनियन। और फिर नौरीन इज माय क्लास का लोग मौजूद हैं यहाँ पे, प्रोफेसर और प्रोफेसर मिर्जा को आप ऑलरेडी जानते हैं। आमतौर पर 8:30 बजे जब सेशन शुरू होता है एक हाल में, तो टेलीफोन हो रहे होते हैं कि यार फलां को बुलाओ फलां को बुलाओ। तो when I came at 8:30 and had been to all 4 halls, तो माशाल्लाह उन तमाम हाल में जो अटेंडेंस थी 50+ हर हाल में थी। और इसमें जो स्टूडेंट्स बैठे और जो ऑर्गेनाइजर हैं, इन तमाम को क्रेडिट जाता है। एंड दिस इज द टीम, रिफ्लेक्शन ऑफ द टीम ऑफ एन इंस्टीट्यूशन। और दूसरा क्योंकि कैमका यूके एक बहुत बड़ी ऑर्गेनाइजेशन है, अपना और कैमकाना के बाद ये आए, लेकिन इस वक्त पैरेलल चल रहे हैं। तो कैमका यूके के तमाम जो ऑफिस बेयर हैं इस वक्त फातिमा जनाब में मौजूद हैं, जिसमें ताबिंदा दोगल हैं और अतर अहमद सिंह हैं, शफीक गिल हैं, गुफैर उनके प्रेसिडेंट हैं, और जो डॉक्टर वर्दा हैं वो कैमका FJ की प्रेसिडेंट है। वर्दा फिर यहाँ बैठी वो ऑक्यूपेशन वाले हैं। सो जो फातिमा जनाब मेडिकल यूनिवर्सिटी की अपनी एलुमनाई है, यूके में वो भी एक्टिव है और KEB भी एक्टिव है। तो आई एम हैप्पी कि दोनों एलुमनाइज देख रहे हैं कि FJ इज एक्टिव। सर आपके लिए बता और उसमें जो मैंने टॉपिक्स देखे, यानी इस वक्त ऑडिटोरियम में शायद साहब आपने चूंकि चले जाना और आपको पता नहीं है, ऑडिटोरियम में कोविड पे बात हो रही है और स्पीकर कौन से? एक्स फेडरल मिनिस्टर फैसल सुल्तान खुद स्पीकर, पाकिस्तान मेडिकल एंड डेंटल काउंसिल के प्रेसिडेंट अरशद तकी खुद स्पीकर वहाँ पे, महमूद शौकत साहब स्पीकर, और फिर हमारी एलुमनाई के तमाम लोग। दे आर टॉकिंग अबाउट द कोविड एंड इंटेंसिव केयर, वहाँ बात हुई। इसी तरीके से मेडिकल एजुकेशन में पब्लिक हेल्थ की बात हो रही है, जिसमें अशरफ निज़ामी और पब्लिक हेल्थ स्पेशलिस्ट तमाम मौजूद हैं, वर्दा शफी वहाँ मौजूद है, हमारे कोलीग्स मुझे मौजूद हैं। और इसी तरीके से एक हाल में बात कर रहे हैं हियरिंग एड की, ENT की, वेरियस अदर पैथोलॉजी, जिसमें डॉक्टर ताबिंदा दोगल और अफजाल आलम और ये टीम सारी मौजूद है इसमें। और आपके हाल में पैथोलॉजी पे बात हो रही है, और पैथोलॉजी का मुझे खुद नहीं पता था कि ये इतना इम्पोर्टेंट सेशन है। जब कॉलेज ऑफ फिजिशियन सर्जन, आपको पता है इस वक्त पाकिस्तान की मेन पोस्ट ग्रेजुएट बॉडी है, उसके में मैंने एक वो अपना एक टॉपिक अचानक फ्लोर हुआ और उसमें मैंने पढ़ा कि मैं एक नई रिसर्च है और वो फर्स्ट टाइम वी आर गोइंग टू प्रेजेंट दैट इन फातिमा जनाब मेडिकल यूनिवर्सिटी। अच्छा, शायद परवेज साहब ने अपने उस लेक्चर के बारे में बात की, तो उससे फातिमा जनाब का एक कॉलेज काउंसिल और उस पर भी एक इम्पैक्ट और इम्प्रेशन पड़ा कि इस कॉन्फ्रेंस का आगाज़ इस खूबसूरती के अंदाज में चारों हाल में हुए और इंशाल्लाह इसी तरह 19th और 19th को हमारी वर्कशॉप है, कैरियर काउंसलिंग पे सेमिनार है और 20th को डिफरेंट टॉपिक पे हमारी डिस्कशन हो रही है। आई थिंक दिस वुड बी वन ऑफ द अनप्रेसिडेंटेड, वेल ऑर्गेनाइज्ड, वेल मैनेज्ड एंड अ वंडरफुल इंटरनेशनल मेगा इवेंट। एंड थैंक यू ऑल द ऑर्गेनाइजर और आप सबका, जितने हमारे फैकल्टी मेहमान बैठे हैं और सब कॉलेज में यहाँ पहले मौजूद रहे, आपकी सारी फैकल्टी इस पर मौजूद है, आप सबका बहुत शुक्रिया। खासतौर पे शायद प्रवेश साहब कराची से तशरीफ लाए हैं। ही लुक्स आफ्टर द पैथोलॉजी इन द कंट्री, पैथोलॉजी की जितनी पोस्ट ग्रेजुएशन है यही लुक आफ्टर करते हैं। हिस्टोपैथोलॉजी का अपना सब्जेक्ट है, लेकिन बाकी हमारी हेमेटोलॉजी है, केमिकल है, माइक्रो है, तमाम स्पेशलिटीज़ हैं। उनकी जो इंडिविजुअल फैकल्टी है, फिर कलेक्टिव फैकल्टी है, फिर उस तमाम फैकल्टी में आगे नई सब स्पेशलिटी प्रोग्राम आ रहे हैं, कुछ इनोवेशन की इवेल्यूएशन में लेके आ रहे हैं। उन तमाम चीज़ों को लुक आफ्टर करने के अलावा हमारा जो बेसिक मेडिकल साइंस का कोर्स है जिसमें इन तमाम बच्चों ने पार्ट 1 करना है, उन तमाम की गाइडेंस और जो गाइडलाइन है वही शायद प्रवेश साहब ने बनाई है। मुझे भी पता चला नहीं कि शायद प्रवेश साहब जाना चाह रहे हैं, तो पहले लेफ्ट द ऑडिटोरियम, मैंने कहा मैं शायद साहब का थैंक यू कर रहा हूँ और फिर डॉक्टर नवीन, प्रोफेसर शफीक गिल और प्रोफेसर मुजफ्फर आप सब लोग मौजूद आए। आई बस से थैंक यू टू एवरीबॉडी। तो आप मेरे ख्याल में शायद साहब
with your permission, just saying that to कल 48 hours पहले एक्टिविटी में ये
असल आप पता है कि फातिमा जना पहली यूनिवर्सिटी थी इस पे शफीक साहब, दिस वाज द फर्स्ट यूनिवर्सिटी जिसने फ्लड में खुद हमारे पोस्ट ग्रेजुएट प्रेसिडेंट हुए। साउथ में जा पहले 2, फिर 7 शरीफ और फिर लाडकाना। और कल आपकी फैकल्टी के सारे लोग जिसमें प्रो वाइस चांसलर प्रोफेसर शमसा, डीन प्रोफेसर जोरा और प्रोफेसर बिल्किस, डॉक्टर इमरान असलम, इन साथ हमारे यंगस्टर मेडिकल कैंप के लिए एंड इनाग्रेशन ऑफ ए विलेज, उस विलेज का नाम काशानी विलेज था, लेकिन अब उसका नाम है फातिमा जना विलेज। और उस विलेज के डॉक्टर आसिफ महमूद जान के साथ कोलैबोरेट किया हमारी एलमनाई में, और एलमनाई के साथ हमारी उनसे हमने स्टार्ट किया। वो 29 घर इस वक्त बन चुके हैं और उसमें घरों के साथ एक सेपरेट डिस्पेंसरी है, वहाँ डॉक्टर की अवेलेबिलिटी, एक कम्युनिटी सेंटर है और कम्युनिटी सेंटर के साथ स्कूल। इन तमाम को एक तो इमीडिएट फ्लड हीलिंग एक्टिविटीज़ है जो मेडिकल कैंप्स, और उस वक्त का जाना है एक रिहेबिलिटेशन है। रिहेबिलिटेशन में लोग भूल जाते हैं, फातिमा जना इमीडिएटली नंबर 1 थी। रिहेबिलिटेशन के स्टार्ट और कंप्लीशन विद परफेक्शन में फातिमा जना रिमेन नंबर 1। 29 घर कंप्लीट हो चुके हैं और 100 घर का टारगेट है एंड रेस्ट आर ऑन द वे टू कंप्लीशन। हमने 20 मिलियन से स्टार्ट 2 मिलियन से स्टार्ट किया, 2 मिलियन से, और वो 2 मिलियन फातिमा जना की अपनी फैकल्टी ने इसका आगाज़ किया। और कल आसिफ जा कह रहे थे कि इन 2 मिलियंस में इतनी बरकत पड़ी है कि these 2 million has attracted 200 millions, और वो साउथ पंजाब के साथ सिंध और बलूचिस्तान में भी रिहेबिलिटेशन का काम हो रहा है। मेरा ख्याल है कि उस वक्त आप अगर सोचें ना कि राजनपुर के आगे फाजलपुर के आगे एक बस्ती है काशानी, और जहाँ 3 महीने गए हैं तो पानी के अलावा कोई चीज़ नहीं थी, वहाँ मट्टी थी, लोग खुले आसमान के नीचे थे। इस वक्त खूबसूरत घर और कुछ उनकी डेकोरेशन भी है, फसलें उनकी दोबारा इसको बन रही हैं, मेडिकल की फैसिलिटी 2 स्टेप पे फ्राहम करने के लिए, और इस तमाम का क्रेडिट जो है आपके इंस्टीट्यूशन, आपकी अलुमनाई के जाता है, और उसकी वजह एक टीम वर्क है, और इस टीम वर्क की रिफ्लेक्शन आज आपके सामने इस सेमिनार में शरीक। सो थैंक यू।
रास्ता जाने का था, 9 घंटे आने का था, रात हम 11:15 वापस पहुंचे हैं।
सर्वाइकल कैंसर स्क्रीनिंग प्लीज स्टार्ट फ्रॉम एफजे, कहीं से तो शुरू होनी है ना, कहीं पहला पौधा लगेगा।
मेरा ख्याल एक 2 एडवाइसेस मैं इनकी भी सुन लूँ, और ताकि मुझे फीडबैक मिल जाए, खासतौर पर शायद फीकिल का, नौरीन अकबर का, नौरीन अपना जफर असल में आपका सर्वाइकल कैंसर एक सब्जेक्ट है, वी स्टार्ट फ्रॉम बिगिनिंग और प्रोसेस हो रहा था ये सब। आई एम श्योर जो कोलैबोरेशन होगी इस वक्त वी हैव गॉट द बेस्ट सेंटर ऑफ इन द नेम ऑफ एमसीएच अटैच टू एफजे। बेस्ट सेंटर है, 600 बेड कैपेसिटी है और 4 नई स्पेशलिटी और इंशाल्लाह उसमें आई थिंक इस पे हमारा मेन फोकस इसी पे होगा। तो गिल साहब शाह साहब आपकी भी थोड़ी सी फीडबैक।
जी सबने कहा और मैं तो बहुत सालों से और उनसे काउंसिल में 4 साल से जो विटनेस कर रहा हूँ, माशाल्लाह अल्लाह ताला बुरी नज़र से बचाए। जो जितनी पॉजिटिव एनर्जी खालिद मसूद मोहम्मद साहब ने मैंने देखी है कि फ्रॉम डॉन, वो तो मिसाल के तौर पे कहते हैं डॉन टू डस्क, ये तो लेट नाइट है। और सबसे बड़ी बात ये है कि आमतौर से कई दफ़ा कोई ज़रूरत होती है, लोगों को फ़ोन करते हैं, कई दफ़ा लोग नहीं उठा पाते, लेकिन यूजुअली आई पर्सनली थिंक कि ये बड़ा इम्पोलाइट है कि किसी को आप कॉल करें और वो कॉल बैक भी ना करें। सर इतनी मसरूफियत के बावजूद भी जो है, मैंने कभी रात को 12 बज जाए, 12:30 बज जाए, 1 बज जाए, कॉल ज़रूर आएगी कि हाँ भाई शायद साहब, वो मैं उस वक्त वहाँ बिजी था, मैंने बात को देखा, क्या मसला है, बट मेरा राइट टू कॉल। दिस इज समथिंग हाईली एक्सट्राऑर्डिनरी। तो एक तो ये पर्सनल लेवल पे है और बाकी फातिमा जिन्ना मेडिकल यूनिवर्सिटी का नाम तो माशाल्लाह फातिमा जिन्ना बहुत इट्स ए प्रीमियर यूनिवर्सिटी, किंग एडवर्ड और फातिमा जिन्ना मेडिकल यूनिवर्सिटी एंड माशाल्लाह आप तो दिस वाज द फर्स्ट वीमेन यूनिवर्सिटी, लेकिन अब इन सारे डेकेड्स में चीज़ें उलट गई हैं। पहले तो ये था कि फीमेल्स के लिए आप वहाँ पर हैदराबाद में जो है वो जो गए थे सर भी कॉन्वोकेशन में, तो पता चला था कि वो मेडिकल कॉलेज फॉर बॉयज होंगे वो बिलावल मेडिकल कॉलेज, और वो लम्स वाले कह रहे थे हम भी अब एक जो है बॉयज मेडिकल कॉलेज शुरू कर रहे हैं। और सर्वाइकल स्क्रीनिंग की जहाँ तक बात है, देखिए इस पे हम काफ़ी काम खान के लेवल पे हमारी है ज़ैनब समद, जिनका के बड़ा चेयर है वो मेडिसिन की, जो कि बिल गेट एंड मेलिंडा के जो फाउंडेशन है उनके साथ बहुत क्लोज में उसमें शामिल उन्होंने मुझे भी किया हुआ है। 1-2 दफ़ा इस्लामाबाद में भी मीटिंग हुई है IR WHO वालों के साथ और बिल गेट एंड मेलिंडा के साथ। तो उनका ये था कि वो कंट्री जहाँ भी 4% से अबव है एज स्टैंडर्डाइज्ड इंसिडेंस रेट, हमारा कोई 4.5-4.6 आ रहा है, तो उनको दे आर विलिंग टू सप्लाई द HPV वैक्सीनेशन फ्री ऑफ चार्ज। तो आई थिंक बहुत मैच्योर स्टेज पे है कि वो लाइक पोलियो वैक्सीन, HPV वैक्सीन भी यहाँ पर अवेलेबल हो जाएगी फ्री ऑफ चार्ज फॉर ऑल वीमेन, फॉर ऑल गर्ल्स जो कि 11-12। और वो जो बात आप सर्वाइकल स्क्रीनिंग की कर रही हैं, मुझे लगता है कि अब इस स्टेज पे विद HPV वैक्सीनेशन तो अब तो इवन मेरा ख्याल में विद टाइम शबीर कल और बताएंगे कि रॉयल कॉलेज ऑफ पैथोलॉजिस्ट ने फॉर एग्जांपल जो साइटोलॉजी का एग्जाम होता है उसमें अब साइटोलॉजी स्क्रीनिंग निकाल दी है उन्होंने, क्योंकि विद टाइम दिस विल पेरिश, क्योंकि जब सारी women will be immunized और vaccinated तो फिर इसकी शायद जरूरत ही बाकी नहीं रहेगी। तो मेरा ख्याल में अब इस स्टेज पे स्क्रीनिंग से ज़्यादा ये इम्पोर्टेंट है कि HPV वैक्सीनेशन अवेलेबल हो फॉर ऑल गर्ल्स। जो बेस्ट टाइम है वही है कि 11 से 13 ईयर्स के दरमियान, और अब तो 2 डोजेज हैं, लेकिन अब सिंगल डोज वैक्सीन के ट्रायल्स भी कंप्लीट हो गए हैं। तो इस पर मेरा ख्याल में विद दैट शफीर साहब को कहूँगा कि वो थोड़ी सी इस पर ज़रा और रोशनी डाल दें कि खासतौर से सर्वाइकल कैंसर और उसके बारे में। सर
शफीर साहब को बुलाने से पहले शफीर साहब एक ही इतला के लिए कि प्री कॉन्फ्रेंस है इस वक्त और एक्टिविटीज चल रही हैं। फातिमा जिन्ना मेडिकल यूनिवर्सिटी में वी हैड आई थिंक कितनी हमने प्री कॉन्फ्रेंस वर्कशॉप की 42, ये हाईएस्ट नंबर है सातों यूनिवर्सिटीज में। और इसमें भी जो इन 42 में हाईएस्ट नंबर जिनका है उसमें डिपार्टमेंट ऑफ पैथोलॉजी और डिपार्टमेंट ऑफ गायनेकोलॉजी।
Khalid Gondal Saab, as he rightly mentioned, he has been just like an elder brother. Our memories go back to 1987, if I remember correctly. So I used to come to Pakistan every year, लेकिन usually वही family के साथ आने जाते और वापस चले जाते थे। लेकिन माशाल्लाह जब से Khalid Gondal Saab के गवर्नमेंट मेडिकल कॉलेज में थे, we started this small interaction, जैसे he rightly mentioned, Canada UK is an organization के scientific sessions. तो साइंस इज ऑलवेज लाइक अ वेरी बोरिंग सब्जेक्ट। आप आते हैं यूजली थोड़े से स्टूडेंट्स अपने बात की चले गए, लेकिन कुछ लोग उस प्रोसेस में जान डाल देते हैं। आई थिंक द जान एक्सक्यूज मी इज डॉक्टर खालिद गोंदल। तो आई थिंक पिछले 4-5 साल से हम आते हैं, तो माशाल्लाह द कैम्का यूके's presence and involvement in promoting scientific development has grown exponentially. And it's just, I think we really must congratulate Dr. Khalid Gondal for making it happen. And we were a little bit worried जब इनका टेलीवर वहाँ पे खत्म हुआ, तो we used to think कि अब next क्या होगा, क्या अभी भी हमें लोग उसी तरह से होस्ट करेंगे, will we get the platform? So not only we are getting the platform at the advert, but mashallah he has moved the whole platform to Fatima Jinnah as well, and we are really pleased with the developing collaboration, because जब हम UK में भी के graduate की annual meetings होती, we have Fatima Jinnah colleagues as well. So I think that makes a very nice combination कि इस चीज़ को हम jointly लेके आगे चलें. And particularly I want to highlight this session for today, breast and cervical cancer screening. Fatima Jinnah, being the premier institute of women medical education in Pakistan, has a great potential to be the premier institute to lead development of cancer services for when we talk of women cancer, both breast and cervical cancer. So I think there is a huge opportunity if we work together. This should be one of the exemplar sites. और जैसे डॉक्टर शाहिद ने राइटली कहा है कि सर्वाइकल कैंसर में आई थिंक ही इज राइट कि स्क्रीनिंग इज देयर। स्क्रीनिंग से ज़्यादा वैक्सीन हैज़ बीन ह्यूजली बेनिफिशियल इन मिनिमाइजिंग द इंसिडेंस ऑफ सर्वाइकल कैंसर। लेकिन उसमें मेजर चैलेंज ये आ रहा है वहाँ पे भी कि वैक्सीन की इम्प्लीमेंटेशन, स्पेशली गर्ल्स में तो इट्स ओके, लेकिन वैक्सीन आपको पता है कि बॉयज़ को भी लगवाती है, एंड उसमें एक एक्सेप्टेंस का जो है वो चैलेंज डिफरेंट। और पाकिस्तान बीइंग एन इस्लामिक कंट्री, आप लोग मुझसे ज़्यादा बेहतर जानते हैं कि वैक्सीन को भी स्क्रीनिंग इज अनदर चैलेंज, लेकिन वैक्सीन की इम्प्लीमेंटेशन विल बी ए डिफरेंट चैलेंज। लेकिन अगेन आई सी यंग फेसेस, आप वो लोग हैं हमारा फ्यूचर, वो विल मेक ए चेंज एंड ब्रिंग ए चेंज, और उस चीज़ की इम्प्लीमेंटेशन को आगे लेके चलेंगे। दैट इज द ओनली वे फॉरवर्ड कि वी कैन रियली हैव से कैंसर फ्री पाकिस्तान। एंड स्पेशली ये दोनों कैंसर जिनकी हम बात कर रहे हैं आज, दे आर प्राइमरली ईदर प्रिवेंटेबल और क्यूरेबल कैंसर। तो जो स्टेट ऑफ अफेयर्स है पाकिस्तान में, दिस कैन बी चेंज्ड provided we all work together and share knowledge and expertise. And we will be discussing as we go on. बहुत सारी बात आती है, we come from the west, कि वहाँ तो पैसा बहुत है, वहाँ तो बहुत आसान होती है चीज़ें, लेकिन I must honestly share with you, पैसा is probably just one factor. Sometimes थोड़े पैसे से भी आप बहुत सारी चीज़ें कर सकते हैं। उसके लिए all we need is collaboration, all we need people willing to make change, and all we need is the right people who can lead the stage and make it happen. Thank you.
लास्ट पॉइंट डॉक्टर नौरीन है कि स्क्रीनिंग और वैक्सीनेशन साइड बाय साइड ऐसे ही।
Okay, for shield presentation, first of all, Professor Zora Khan. Dr. Shafiq Gill. Dr. Noreen Zafar.
आप भी थोड़ा साइड पे।
Dr. Zainal Hafiz. Thank you very much, sir.
Thank you very much. और फिर at 11:40 ऑडिटोरियम में सब इकट्ठे होंगे एक कंक्लूडिंग सेशन के, और इस तमाम जो एक्टिविटी हो रही हैं इसके जो रूह रवा हैं वो डॉक्टर अतर अहमद से ही हैं।
UHC, there are many team assessment tools out there. If you use what's best for you, it's something that can be spoken as well. So, for example, onset. When did the pain start? Is it new? Is it something that's been there for a long time? A lot of patients, when they talk about pain, it's about finding out, is it a new pain? Is it related to their cancer? Is it something that's happened for the last few months, few weeks, few years?
Okay, we'll move on to our next presenter. Our next speaker is Dr. Academy Islamabad. She'll talk about early detection of breast cancer, effective strategies to make a difference. Please, Dr.
I'm going to talk a little bit about the early detection of breast cancer, and then I'll play a little video. We've been running a breast cancer campaign, so I'll play a little video after the presentation. So, my presentation is dedicated to all those who have lost their lives but never gave up, and to all those who won't quit the fight. I'll start with statistics. Just to look at the fact that breast cancer is actually perhaps looming pandemic, or at least a looming pandemic in Pakistan. We'll talk about the statistics in Pakistan later. I've taken these from World Health Organization's website. There were an estimated 18.1 million cancer cases worldwide in 2020. Out of those, 8.8 million cases were in women, and breast cancer was the most common cancer, contributing to 25.8% of the total number of new cases. In 2020, there were 2.3 million women diagnosed with breast cancer, and around 700,000 deaths globally due to breast cancer. At the end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer in the past 5 years, making it the world's most prevalent cancer. There are more lost disability adjusted life years by women with breast cancer globally than any other types of cancer. Incidence of breast cancer in Pakistan: 1 in every 9 women will be diagnosed with breast cancer at some point in their life in Pakistan. Pakistan, unfortunately, has the highest incidence of breast cancer in Asia. It is estimated that over 83,000 cases of breast cancer are reported each year. It claims the life of about 40,000 women in Pakistan every year. And I feel these are the recorded stats. I've taken them from Shaukat Khanum's website. But I feel that there are many more cases that perhaps we don't have a robust system, a cancer registry. So I think there are many more cases that are recorded on the system. So we ran a breast cancer awareness campaign, and the title was Early Detection for Your Protection. Because it is a cancer, if detected early, the treatment strategies are quite effective now. So when we talk about early detection program, in order to improve breast cancer outcomes and survival, early detection is critical. It has actually two components. early detection program for breast cancer. One is early diagnosis and one is screening. When we talk about early diagnosis, it is the awareness of public and general public and health professionals about early signs and symptoms of cancer to facilitate diagnosis before the disease becomes advanced and enable effective and simple therapy. In a population where the majority of the cancers are diagnosed in late stages, an early diagnosis program is the most feasible strategy to reduce advanced disease and improve survival rates. So obviously greater chance of survival if breast cancer is detected early on. So I'm just going to show this diagram that I think I've taken from one of the WHO documents. This is between early diagnosis versus screening. So what happens with screening is that we do it for a targeted population, and we are able to pick up pre-invasive cancer or cancer before any symptoms are evident, while early diagnosis starts after the onset of symptoms, right at the onset of the initial symptoms. If it is picked up, then it is early diagnosis. So, when we talk about steps to early diagnosis, because we talk about strategies to improve early detection. Steps to early diagnosis. Step one is awareness, obviously awareness for healthcare professionals as well as the general public, and accessing care. So awareness of symptoms, and then the awareness to seek appropriate help to when needed for those symptoms. And then step two is clinical evaluation, diagnosis and staging. When the symptoms are, when you present to the clinicians, they should be able to do the clinical evaluation and should be able to diagnose properly or refer you if you are presenting to primary, the patient is presenting to primary care, and refer them to the appropriate service, so appropriate referral services. And then the third step, access to treatment. So step one, when we talk about these steps, awareness and accessing care. So step one, breast health awareness. So when we say that the incidence of breast cancer is highest in Pakistan, 1 in 9 women will be diagnosed with breast cancer in their lifetime. So we think, and the incidence is increasing. We do think it makes one wonder what are the causes? Why the incidence is higher? Why is it so prevalent in our community? When we talk about the risk factors, there are modifiable risk factors for breast cancer, and then there are non-modifiable risk factors. Non-modifiable risk factors like race. Looking at the stats, it looks like it's commoner in white women. But I just wonder, it looks commoner in white women due to the fact that perhaps the cancer registry recording of data is more robust in the Western countries. And then in black women, they can have cancer at a younger age and can be quite aggressive. Then the non-modifiable factors is obviously more common in women, 99% in women as opposed to 1% in men. Then the non-modifiable factors include some of the inherited breast cancers, although just 5 to 10% of the cases that are due to the genetic mutations, common ones, BRCA1 and BRCA2. So these are all non-modifiable factors. We really can't change them. But then there are modifiable risk factors. And I think one of the take-home messages today would be to work on those modifiable risk factors to decrease the incidence of breast cancer. We talk a lot about being overweight or obese, when we talk about hypertension or diabetes, we talk about sedentary lifestyle, and to change it with exercise. We talk about smoking and alcohol, then we talk about other health problems. But it is important to remember that all these things, being obese, having sedentary lifestyle, certain kind of diet, not doing regular exercise, and tobacco, alcohol, they are all risk factors for breast cancer as well. And by modifying them, we can decrease the risk of breast cancer and eventually decrease the incidence of breast cancer in our communities. So step one, breast health awareness. It is important to understand the factors, the modifiable ones and the non-modifiable ones, and to work on them. There are certain other ones like modifiable ones like use of contraceptives, hormone-resistant therapy postmenopausal women, especially if they're using it for more than 5 years. So generally to improve knowledge and awareness among the target population, know your normal. It is important for women to be breast aware, perhaps after the age of 40, do the regular breast examinations at least once a month. I'm going to talk about screening later in the presentation. Self-breast examination broadly is considered a part of screening, although some people argue that only mammograms is a real screening, but in a country where the resources are deficient, just to give awareness to women, for them to know their normal, encourage them to do self-examination once a month, I think is very important for all of us. What to look for? So the things to look for, to tell our patients, to tell the general population. And when I talk to younger people like you, to students, one of the motivation is that I'm just not talking to the 50 or 100 ladies in this hall. What I believe is that you'll take this message home, you'll tell it to your friends, your family, and it will help spread the message far and wide range. So the things to look for is any sort of abnormal nipple discharge, including blood-stained discharge, any lump of thickening, skin coloring, any lumps in your armpit, any dimpling of your skin, inverted nipples, so these any irritation of your skin. Breast pain, perhaps a symptom of breast cancer, but I don't think it would be an early symptom. Never say never, but generally not an early symptom of breast cancer, breast pain, is what I've seen in my clinical practice. So step 2, clinical evaluation, diagnosis and staging. So this is where our physician had, the breast surgeon had, the histopathology comes into place. But this patients will reach this stage only if there are robust strategies to guide them, to educate them in the first instance, to reach this sort of one-stop breast clinics, to be referred to these sort of breast clinics or outpatients if they've been seen promptly by, if they are aware of the breast, they know the symptoms, they've been seen promptly by their GP and they have been referred. So obviously we need the public health campaigns in general to raise awareness, but robust referral pathways and integrated healthcare system really. Now I'm going to talk about the clinical breast examination. So as a physician, as a clinician, we only do the breast examination if a patient comes in with symptoms, isn't it? We will not examine, we will not do an intimate examination if the patient does not have any symptoms. Here we put broadly clinical breast examination into screening as well. But you can, but at the end of the day, you wouldn't examine somebody if they don't have any complaints. You can only do that if they come to us. So I think the first step is to raise awareness in the patients. But then yes, clinical breast examination has its own value, done for the right patients. So yes, then again the robust referral pathways. One-stop breast clinic, I was looking into it. There are a few in the bigger cities, but this kind of services, this kind of approach, triple assessment with the breast surgeon being there, specialist breast nurses, radiologists who can do the ultrasound guided biopsy, mammogram facilities, to bring everything under one roof, I think is a very good idea. Because once you present with a breast lump or any breast symptoms, the women don't want any delays, seeing too many different people in different clinics, in different hospitals or different settings can be quite daunting for a patient. So history taking, structured history taking in the same clinic, then obviously appropriate data collection, personal and family history, review of symptoms, clinical breast examination, yes, and then obviously radiology, mammograms and ultrasound as age appropriate. Then obviously taking the samples, if done under one roof, I think it can be very helpful. So staging of breast cancer done appropriately, and then step 3, that is also important. Once we are running the massive public health campaigns, we are raising the awareness, we are telling people about the signs and symptoms, the incidence and prevalence of breast cancer, how we have such high rates. We're talking about the modifiable and non-modifiable risk factors. So we're preparing a better population. But then at the same time, we have to think about access to treatment for all those who are diagnosed with a condition. That in the whole cycle or in the whole loop is very important. So, delays and barriers, we'll talk about in these steps, in having awareness, accessing care. So, for health literacy, then there are stigmas, there are myths attached to breast cancer, there's stigmas still, unfortunately, in our society. They need to be addressed, we need to challenge the dogmas. People have limited access to primary care. That's another thing. As I said, we need to have an integrated healthcare system where people have their own family physicians, women are comfortable to go and talk to them, have long-term relationship. Then obviously, there are clinical barriers in terms of what is available. The robust referral pathways are needed. Then we need the physicians that can do the assessment, and then the appropriate treatment facilities for a bigger population. How to strengthen early diagnosis. So we've spoken about public health campaigns, we've spoken about raising awareness, challenging the busting myths and challenging the dogmas, having robust referral pathways and an integrated healthcare system with access for all, and universal health coverage will help improve things. Screening. It refers to the use of simple tests across a healthy population to identify those individuals who have a disease. The restricted criteria for a screening program to be implemented. I've written some here from WHO. We need to, but do not yet have symptoms. So picking up the patients who have the very, very early disease. They should be undertaken only when the effectiveness has been demonstrated, resources are sufficient to cover the entire target population or target group. When facilities exist for confirming diagnosis, that's very important. When treatment and follow-up of those with abnormal results can be done. It's not only about establishing a screening program. We have to see the end point, that those who have been picked up, the screening after screening test, the diagnostic test can be done on them. And then if they are positive for a condition, they need to be referred promptly for treatment. So we need to understand the whole cycle, the whole cycle of the disease before we implement a screening program in a population. So various methods. I've talked about breast self-examination, clinical breast examination. Some argue that strictly speaking it's not a part of screening. I would say perhaps we need clinical breast examination, but at the moment in a country where health systems are fragmented, we're still trying to implement a lot of guidelines and new things. Self-breast examination once a month by women themselves is not a bad idea. They should know they're normal, and if there is anything that doesn't look right, they should be advised to seek help promptly. Mammography, obviously, plays a central part in early detection of breast cancer, because they show changes in the breast much before a patient physician can feel them. So, American College of Radiology, we have here is the separate cancer screening unit, breast cancer screening unit, and they follow American College of Radiology guidelines. So, a mammogram every year for women beginning at the age of 40. NHS screening program, they start screening for women at the age of 50, do it till the age of 70 years, every 3 years. Let us talk about the X-rays, because a lot of people are concerned that because it's X-rays, so how much radiation do you get? I've spoken about the Federal Breast Cancer Screening Unit. It's the first ever public sector facility located inside the Pakistan Institute of Medical Sciences, Islamabad. It provides free screening mammography for women of all socioeconomic strata and is a walk-in facility. But obviously that's not enough for the entire population. So the recommendation is to initiate a policy dialogue for establishing a national screening program. This would also require channelizing resources in improving the diagnostics, treatment and follow-up facilities. As I said, we need to sort of then implement the whole cycle if we think about rolling out screening program for any problem. So breast cancer has high cure rates when detected and treated early. Thank you. I'd like to, I'm running out of time, and I'll be given the warning, but I'd like to play a little video if that's okay. breast cancer awareness campaign extensively. We normally the Pink October or Pinktober, but we intend to run it throughout the year in collaboration with President House this year. So I think it's a big motivation. I've been to several universities in the Twin Cities. I think we need to sort of spread it across the country and just not stay limited to the Twin Cities of Islamabad and Pindi. But still, it's an effort we're trying to make to raise awareness. And the questions, obviously, I've been to the medical colleges, but more so into just the general university, the life and sciences, the humanities, just to raise awareness in the young students. And the questions they ask me, it's really stimulating how much people want to know and how much they need to know about this condition. This is a picture of my mom and I. My father took this picture almost a decade ago. My mother had breast cancer, and unfortunately it had already metastasized by the time it was diagnosed. We as family have been through this tough journey of cancer diagnosis, treatments including hormonal therapy, surgery, chemo and radiotherapy. We lost her, but I feel she didn't give up until the end, and I never lost hope. My mom's fight against breast cancer has taught me perseverance, resilience in the face of adversity, and kindness. I feel privileged that I've been able to run this campaign, as this is a cause very close to my heart. I'm sure if not all, most of us have a friend or family member who has been diagnosed with this condition. We all have stories to tell, some with happy endings and some are quite tragic. However, the pledge today is that no matter whatever the end of our story is, हम अपने हिस्से की शमा जलाते जाएंगे. We'll continue to spread awareness and save lives. I'd like to end saying, शिकवा इस ज़ुल्मत शख्स से तो कहीं बेहतर था, अपने हिस्से की कोई शमा जलाते जाते.
Thank you very much, Dr. Zainab, for such an informative and very elaborate presentation. And I would invite Dr. Muhammad Shafiq Gill, and he will talk about holistic breast cancer service, important to increase survival.
Good morning. I think Zainab has made my job really easy. I think she has brought it to. We talk about cancers, we talk about cure, we talk about screening, everything. But sometimes, I think as one of the other speakers mentioned earlier, it looks like ये तो किसी और का मसला है, हमारा नहीं होता. I feel I'm in the right place to talk about breast cancer. I just wanted to ask you just a very simple question, just to make it a bit personal, is, do you know and have you seen any patient with breast cancer? Yes. Have you been involved in their care in any form and shape? Can you just raise your hands, please? And if I ask you a simple question, if you go back, did you get the feeling of जिस पेशेंट को जो ट्रीटमेंट मिलनी चाहिए थी वो सही ट्रीटमेंट सही टाइम पे मिली? Because that is the one element. I have been dealing with breast cancer. I think I started my pathology training in 1993. And when I did my FCPS part 1, Dr. Farooq Kumar was my teacher. I started training with him. But there were only very few institutions in Pakistan जहाँ पे उस वक्त FCPS की training होती थी. So I started doing it. And then I moved to our university hospital. And in 1997, I was involved in like reporting breast cancer. And UK sitting in the breast cancer entities. I think we talk of huge success, and there has been really huge success, but when we look back sometimes, when we talk of individual patient, there is always a feeling we could have possibly done a little bit more, which would have made a huge difference. And the reason I'm saying that, especially Pakistan, breast cancer is a disease of relatively young people. Just like Zainab brothers have mentioned, when we say 1 in 9, just try to imagine what does 1 in 9 mean? Every 9th person. Especially it starts from the age of 30 onwards. And then when you talk of 1 in 9, can you imagine your own friends, your family members, your colleagues? And that's exactly what I have experienced in my life now when I talk wherever I work, especially healthcare as a field, there are more females. I hear every year within my colleagues, breast cancer, or they have a problem, and all those things. So I think it's just understanding, it's becoming more like an epidemic. So we have to look at, have we got the right facilities? again, sometimes we talk about money, but I think it's more than money. It's about being aware, developing the right systems, and working to look for proper care systems which can help us. So just a bit of background. I think the healthcare can be a little bit fragmented. So when we look at the person, usually it's a young female, usually married, maybe it's a bache when they get diagnosed with breast cancer. And that's where it affects the whole person. It's not just like the flu, maybe people go through various stages of this diagnosis, treatment, post-treatment, and then it's a lifelong psychological impact of survivorship, of being someone who had cancer. And every patient has their own journey. They will tell you their own personal stories, how have they been through that experience. And when we talk global level, every country, every society has their own way of it. I have a bit provocative because I'm dealing. It's not curing or handling, it's how the experience patient gets. And I think that's the bit we need to focus on. उस process से जब patient गुजरता है, उनके साथ क्या experience होता है? Is it a good experience? Do they get the right care? Or is there something we can look at very differently? So I've just picked up a copy of Maslow's basic theory of needs and just copy pasted the breast cancer theory on that. So every breast cancer patient has what we say physiological needs. It's the disease, उसकी pain है, उसमें जो है वो उसके side effects and treatment के साथ. And then it moves to how do they feel about it? Do they feel safe? Do they have loved ones around them who will support them? How their personal feeling is, and then obviously are they prepared to live with it? Unless we sort out the very bottom layer, I think we cannot even talk about the above. And I think if you know a breast cancer patient, just have a conversation with them, and they will give you a very good idea. They even struggle to get the basic ones. I don't think they went up to the next stage, and I think that's what we need to look at. So we talk about early diagnosis, but I will take you to one step before that is pre-diagnosis. And especially that's more relevant to Pakistan, but I must admit even UK goes through similar experiences. It's the psychological state we carry, and when I say we, like young people, yourself, or all of us, by the time we have reached 20, 25, we have developed our own personality, our own understanding, our own psychosocial states. So we carry our own ideas and thoughts about those things. So again, I don't want you to imagine, but if you try to imagine as if in someone else's place, how prepared people are about breast cancer. Do they know, is it a disease, can it be treated, should they seek diagnosis early? Or what are the myths they carry in their own mind, that it's a death sentence, it's very expensive, there's a social stigma related with it, it will affect your relationships, in your family, and sometimes patients, especially when we talk of cost involvement and all those side effects, patient actually becomes a social liability. Even the family does not want to own them, especially when we talk of young patients who are just married, have 1 or 2 kids, they have moved to a different family. So for that family, sometimes suddenly they become a challenge. And I've experienced that in the UK as well, because in the UK the benefit we have is like the pathology computer system we use. When we were earlier talking about cancer registry, it goes back to 1988. So when you enter any patient details when you come to breast cancer, usually you can pick up the whole history of pathology going back all those 30, 35 years. And one phenomenon, because I report some other cancers as well, one phenomenon I especially noted with breast cancer, patient comes for diagnosis, you do core biopsy, the results are there. By the time you move on to the resection stage, the surname changes. And that happens in the UK. And then I asked one of the breast cancer nurses that I'm noting the surname changes, what happens? And then even she was surprised, but she then started looking at me, she said actually the relationship breaks down. So even in a developed country where health is free, its awareness is very high level of awareness, treatment is completely free, they get the world-class treatment, but still उस burden को family sometimes carry नहीं कर पाते. And it's not the family, it's the female herself. So that's the reason I'm going back to the psychosocial state. कि person खुद ही उसको they get overwhelmed with the whole process कि पता नहीं क्या हो जाए, and that's how the relationship breaks down. So it does not just affect the person, it affects their whole surrounding or the whole family structure. So I think that's the reason I'm saying we have to look at that stage when Jan was talking about the awareness campaigns, whether it's cervical cancer or breast cancer. We have to go back into the minds of those people, and that's all of us. Why is it such a big stigma? Maybe the experience, and they're not sort of idiots, they're very intelligent people. maybe the way we provide them the care, जो उनके जानने वालों को experience होता है उसकी बुनियाद पे, they don't want to go through even the phase of early diagnosis because they are so worried and they know once the process starts, it's going to be like going through a roller coaster. So self-examination, Zanab is right, it's a little bit questionable in terms of really picking up the breast cancer. There are differences. Because when we talk of UK, the average cancer size is 1.3 centimeters. When we talk of Pakistan, it's 2.3 centimeters. So by the time it becomes palpable, it's about 1 centimeter size before it starts becoming palpable. By that time, the cancer cells have divided for 30 to 40 times, as Dr. Shahid was mentioning earlier. Most of them, they have acquired significant mutations. So yes, it's very helpful, but it's not something we can rely on that. So we have to look at other models of picking up cancer early. And that's why many developed countries have started screening programs. UK started its screening program in 1988. And again, yes, we talk of lack of education, everything in Pakistan. But even in UK, if you look at the graph on the right-hand side, I think the highest pickup rate was in 2010 and 11. 73% people went for their screening. It's free. It's offered close to their home, but still many people don't want to go for it, to have their sort of the free screening. And it has been falling, obviously with COVID, it has fallen significantly. So, and then the other option is we can do high-risk family history screening, but that takes up only a small number of breast cancers. Now screening, yes, developed countries can afford it. It's like you screen so many patients every year, and very few will actually have the cancer. So just like finding a needle in a haystack. It has its benefits, because in UK roughly saves about 1,400 lives, and that's about 1,400 families actually, when you look at that perspective. But it's hugely expensive. But still, if you look at the cost-benefit ratio, I think it's still worth the exercise because it saves lives. And maybe as we are getting now big data, better data handling situations with artificial intelligence, we can maybe do this, achieve the same outcome but with less expenses. So if you look at the treatment side of things, the treatment for breast cancer used to be very simple because the concept was it's a very localized disease. If you remove the breast, it cures the disease. But I think we have moved on from that one. So the real journey for the patient then starts once it has been diagnosed, then what type of handling they get. Do they get the right treatment? And is it like a single shot treatment where they just go to one hospital and all the treatment happens? They have huge changes. We know in the last 20 years it's not a single disease. Actually, as we now have access to various tests, especially molecular tests, which can look at the tumor biology, we know actually we talk breast cancer as one disease, but actually beneath there are multiple different types of cancers, like basal type cancer, like genetic associated cancer, and they need slightly different treatment. So there are better treatment options now, but the challenge is, are we able to provide those treatment options to the right people at the right time? So now when we get a breast core biopsy, we can look at all of these, and this is just from your book from Robbins and Kumar. So we can do basic H&E testing, we can do all these estrogen receptor, progesterone receptor, and we now even can do molecular testing to give you an exact idea of two things. One, what type of cancer it is, and second, more important thing is, what type of treatments it will receive. And that's another challenge, because sometimes we give chemotherapy to patients who do not need it. We give some treatments to patients who do not need it, and chemotherapy has its own side effects. So sometimes it's how we use that limited amount of money we have. So maybe if we invest in the right tests, that will help us to make sure the right patients are treated at the right time. So the new preferred treatment is now breast conserving surgery, which is basically lumpectomy or white double excision we call it. And that is a global move away from mastectomy. So you only remove the tumor, there is no need to remove the whole breast. And the reason it becomes very important is, again, when I was talking about the social or the psychological impact, and I don't need to tell how, sort of all follow females, how important it is to their personality and to their psychological well-being. So the aim is not to remove the breast, just the tumor. But then to do that successfully, we need then help from other team members like radiologists who can really give an idea where the tumor is exactly within the breast, or where it looks like, and to the pathologist to then give us an idea that yes, it has been completely excised and there is no need to remove the whole breast. And that means then the new way of managing breast cancer is not a single-handed surgical practice. And I can possibly safely quote now, when I was your age, medical student at medical college, I think a very famous professor of breast surgery at Fatma Jalan used to take pride in 20 mastectomies in a day. So So it used to be a very single-handed practice, but I think now it has changed. You need a whole team of individuals around who can look after the patient. And when we talk of team, yes, I think even if you talk in Pakistan or anywhere in the world, there are teams. So you have surgeons, you have oncologists, you have radiologists, but sometimes we have to look at, is the team serving the purpose? So yes, there is a team. They are all focused on the patient. They are all focused on the patient, but where is the patient in this? Exactly, and I think more in Pakistan than in UK. I think UK is a relatively better position. I would say. What happens to the patient once they get diagnosed with the breast cancer? If you talk to the team, they will say yes, we provide an excellent care. But if you talk to the patient, एक स्कैन करवाना है, बायोप्सी करवानी है, बायोप्सी के लिए कितने बजे पहुंचना स्कैन के लिए, वहाँ पे जाना, 3 हफ्ते बाद रिपोर्ट मिलेगी, एक अपॉइंटमेंट इधर है, एक उधर है, तीनों में साइड इफेक्ट्स हो रहे हैं. For the patient, usually to look after their own family, it becomes a real challenge. So sometimes the team wins, but then you can't even find the patient because they're lost, they're gone. So again, when you talk to teams, they tell you all the success stories, we provide excellent care, but usually patients are falling through the cracks because they are not getting what they need. So that's where the concept came that we need to have multidisciplinary or joint up care, and United Kingdom started this in 1998. So basically the mandate is that every patient should be discussed in a multidisciplinary team, and their treatment plans should be discussed. So when we talk of team has like regulatory requirements that every team should have a surgeon, 2 oncologists, 1 radiation oncologist, 1 medical oncologist, a radiologist, histopathologist. But the most important, which makes a huge difference, is breast cancer specialist nurse. So they are the real people who talk to the patient at their level and then who take care of what the patient needs. So I think that has been a huge success, and obviously you want other team members as you need. And is this system working? So yes, we can have all of our own arguments, but if you look at the data from UK in the last almost 10, I think it's about 40 years now, the incidence has been rising, the blue line. So there are more and more patients being diagnosed, especially because of the screening program. But the mortality is going down, while Pakistan is the other way around. So are the teams working? Is it making a difference? And that's where the proof comes. The mortality is going down because the teams are working and they're making a difference. And there are some meta-analysis coming out as well that show that there is the multidisciplinary or joint up there, which really helps the patient in saving their lives. And when I say saving lives, breast cancer is really a curable disease most of the times. So if you diagnose 100 cases with breast cancer today, actually 80 patients, if properly treated, 80 patients will die of something else, not their breast cancer. And that makes a huge difference in terms of giving us an idea. It's a treatable, curable disease if we set up the right care systems. So what that means is more recently than we have been looking at that, yes, the MDT may be working very well. But are we, once the patient has survived, are we taking them through the next journey in their life in terms of, are we helping them through the right follow-up so that the recurrence does not happen? And then are we taking into account their, what we call the holistic needs, like psychological needs, social needs, financial well-being? And then is every patient getting a care plan and the treatment summary? And that's again where the challenge comes when you say you have seen breast cancer patients. If you just ask them, reports will you ever see a written down proper workup case की diagnosis क्या थी, tumor कैसा है, इसको treatment I get approached by many patients from Pakistan and I ask them अपना paperwork भेज दें. I see big gaps. Usually उनको they don't even know उनको treatment क्या मिलेगी, उनका grade क्या था, tumor का size क्या था, and if you want to get slides, that becomes a bigger challenge. So that's what's happening by law now is every patient gets a care plan, a written treatment summary, and then health and well-being support. Obviously, the MPTs is not perfect. There are about 150 cancers like centers or MPTs in the UK. Not all work at the same highest levels. There's an ongoing process. They set up their own standards, develop teams, and measure progress, and then ultimately look at is it making a difference. And I think that's where the challenge comes. Then it's like an ongoing cycle of improvement. So in summary, it's not a death sentence. So, but we have to go back and change it in the minds of people who start with that worry that it is a death sentence. Actually, it's not a death sentence. And if you look at the last 2 decades, there has been a transformational journey in terms of improving the survival from the breast cancer. And it's on the one hand, it's a lot of money involved, but actually, if you look at, even Pakistan spends a lot of money on breast cancer, but it's how we use that money in a collaborative and integrative way. We can make a huge difference there. So the challenge is it multi-agency, is it multidisciplinary care, which is joined up, which helps with early detection, as I mentioned earlier, which can then also support patients in their survivorship after they have been diagnosed and treated with breast cancer. And then are the teams willing to carry on constantly improving their performance? That is the real challenge, and there. So that I think that's where we can make a difference with whatever limited resources we have. Thank you.
Thank you very much, sir.
Any questions? There are so many.
You can involve the presenters then.
Shazad sir, he was talking about, I'm Professor Farooq Kumar, जिनको नहीं पता है, बाकी लोग पता बच्चों को, was a professor of pathology over here, but in pathology, ये मेरा student है, ये professor मेरी student है, शायद और मैं करते थे, FCPS करके किया था. That was why the incidence has increased. So many people have talked about so many factors like not the lack of exercise, obesity, high sugar, and so many things. But these things were there 30 years back as well. What is new? Why it has gone into the younger? I have got this at a number of places with the students, with the audiences. कि नई चीज क्या है ये 30 सालों की, वो हमने कभी भी जिक्र नहीं किया. इस वजह से जिक्र नहीं किया कि उसके पीछे बड़ी बड़ी चीजें हैं. That's the chemicals. हर किसी को पता है कि 30 साल पहले केमिकल्स तो नहीं थे ये जितने आपने कभी नहीं सोचा. हमने ये पे ट्रिपल्स वालों के साथ भी मैंने बड़ी दफा ये वाली डिस्कशन इस पे की है कि दैट्स अ केमिकल, हम सी ऑफ केमिकल्स में रह रहे हैं और इसको हम एज अपना एक स्टेटस सिंबल के तौर पर यूज करते हैं कि हमने सर्दियों में भिंडी खानी, आउट ऑफ सीजन फ्रूट लेना है, ऐसी दुकान पे जाना है जहाँ मक्खियाँ नहीं बैठी, वहाँ से फ्रूट लेना है. क्यों नहीं बैठी मक्खियाँ? उस पर केमिकल्स फेंके हुए थे. हमने केमिकल्स से उनकी ऐसी चीजें इंक्रीज की हैं. सो वी शुड ऐड दैट केमिकल. और जब हम कहते हैं ब्रेस्ट कैंसर इज नॉट प्रिवेंटेबल और नॉट ऐसा है कि जो कि सिर्फ इसको अर्ली डायग्नोज कर सकते हैं, आई डिफर विद इट. वी कैन डिक्रीज इट. हम इसका इंसिडेंट डिक्रीज कर सकते हैं बाय डिक्रीजिंग दोज केमिकल्स को हैंडलिंग का तरीका होना चाहिए. आप जाएं गाँव में देखें कैसे करते हैं, केमिकल्स बढ़ गए, दे डोंट नो हाउ टू हैंडल इट. वैसे उसको केमिकल्स को यूज करी जा रहे हैं, ऐसे साफ किया, खाना खाया, ना जाके नहाया और वो सारे कैंसर बढ़ रहे हैं. दिस इज फॉर द फर्स्ट वन. कैंसर इंडस्ट्री मैंने ऑलरेडी बात किया था. अब देयर वाज अनदर टॉक है, ये जो अभी शफीक ने किया, टीम. यू आर लकी, एफजे में जो टीम है फॉर सो मेनी इयर्स. We are having the largest breast clinic in Lahore. यहाँ पे breast clinic outdoor में pathologists are available, surgeon is available, radiologist is available. तीनों उस outdoor में available है, जहाँ पे रोज बहुत ज़्यादा मरीज आते हैं. यहाँ पे एग्जामिन होता है, अगर नीड होती है फाइन नीडल वहीं पे होती है, वहीं पे उसकी अल्ट्रासाउंड होता है. और for the older one, they give the time for the next day for mammography. Then oncologist was also with us. ये पूरी टीम हमारी यहाँ पे चलती रही है. और integrated services and then the जो के services बहुत सारे बाहर से आते हैं, उनका ख्याल है यहाँ नहीं available. All receptors are available in pathology department over here. उसकी जब core biopsy होती है या उसकी नोपैक्टमी करते हैं, उसकी फिर उसके रिसेप्टर्स होते हैं, एंड देन ऑन्कोलॉजी वाला उसको टारगेटेड थेरेपीज अवेलेबल फॉर ऑल पुअर पेशेंट्स. उनको हम इंजेक्शन फ्री भी देते हैं, 14,000 का इंजेक्शन, जो 14 लाख का इंजेक्शन, जब उसके इतने पैसे होते थे, हम यहाँ से मंजूर करते थे एक्सेप्टेड के लिए और न्यू पॉजिटिव के लिए. इट्स अवेलेबल जरूर है. अवेयरनेस ये स्टूडेंट्स हैं. आई ऑलवेज टेक 1 full लेक्चर अबाउट दिस ब्रेस्ट प्रिवेंशन और उनको कहता रहा हूँ, हमेशा कहता हूँ, एक तुमको 8 को 10 को तुम बताओगे तो ये बहुत सारा को पता चल जाएगा. दिस इज द मैसेज एंड यू आर द स्टेक होल्डर. सो एवरीथिंग, सो दिस अवेयरनेस जब हम आपस में डिस्कस करते हैं तो फिर नए एवेन्यू खोलते हैं कि इसके बावजूद भी क्या प्रॉब्लम है. जब मैं कहीं भी नया ये FNS शुरू की थी ना, तो अगर 20 की FNA करता था तो 1 कैंसर होता था, अब 10 कैंसर होते हैं. वो इतने सालों में कोई चीज तो नहीं आई है ना, और एज भी नीचे से, और अवेयरनेस हो गई है. मैं नहीं कहता नहीं हुई. अब हमने यंगर में इसीलिए डिटेक्ट करने लग पड़े हैं ना कि अवेयरनेस है स्टूडेंट्स में भी, यंग डॉक्टर्स में भी. एक क्वेश्चन शफीक से, in some literature they say instead of mammography, MRI should be done. I want his comment upon it.
Thank you. Well, just come first straight to the question. You're right. Mammography has its own limitations in terms of picking up cancer, especially as we are moving towards more younger patients. Young breast is dense, and sometimes it may not pick up smaller hidden cancers. And that's where MRI is really helpful. The other area where MRI is much more helpful is when we develop lobular type of breast cancer, because it's more individual cells infiltrated by. उसमें कैंसर को मेमोग्राम से पिक करना sometimes quite risky. But if you have mammogram plus MRI combined, it not only picks up the cancer but also gives you an idea of the cancer size as well. And then especially if you're doing for breast conservation surgery, then it's a better result with that. So MRI definitely helps. But MRI is generally much more expensive as compared to mammogram. That is the only limitation. Other than that, I think especially for young patients, it's much more useful.
Thank you very much, sir, for your valuable thoughts, and of course, sir, for concluding the session as well. And I would like to thank all the honorable speakers, the chair, the faculty, and the lovely students for being here and making this event a success. And I request